check.
Minutes. 5 minutes, so let's wait 4 minutes.
ეს უნდა იყოს აქ, ხო?
ეს შეგვიძლია.
კაი, ბატონო. If you let me know when I post it.
I'll let you know.
Okay.
Soru bittikten sonra mikrofonu kapat.
ძვირფასო მეგობრებო, მოგესალმებით ჩვენს კონფერენციაზე, თბილისის საერთაშორისო კონფერენციაზე ნუტრიციოლოგია და საზოგადოებრივი ჯანდაცვა. ჩვენი საზოგადოება, საქართველოს ნუტრიციოლოგთა საზოგადოება, ბრიტანეთის და ირლანდიის ნუტრიციოლოგთა საზოგადოებასთან ერთად, ასევე სანიტარიის, ნათათის სახელობის სანიტარიის ჰიგიენისა და სამედიცინო ეკოლოგიის ინსტიტუტთან ერთად უკვე მეოთხედ აწყობს კონფერენციას. ამჯერად ჩვენ შემოგვიერთდა დელეგაცია თურქეთიდან, ეს გახლავთ საბრიოლკა ფონდი, რომელიც ხალხში ამოგვიდგა და დაგვეხმარა, რომ ეს კონფერენცია ჩაგვეტარებინა ასევე. ჩვენ ძალიან დიდი მადლობლები ვართ ამ ორგანიზაციის, რომელმაც გამოხატა სურვილი, რომ ითანამშრომლოს ჩვენს საზოგადოებასთან და შევქმნათ ჩვენ საზოგადოებასთან, რომ გავავრცელოთ ნუტრიციოლოგია და ნუტრიციოლოგიური მეცნიერება საქართველოში. Dear friends, welcome to Tbilisi International Conference, Nutrition and Public Health. Georgian Nutrition Society and Georgian Nutrition Society, the Nutrition Society of Great Britain and Ireland, an Institute of Sanitary Hygiene and Medical Ecology, are organizing this conference. It's our fourth conference. But this time we are joined by the organization from Turkey, Sabri Olka Foundation, and who brought the eminent speakers to do presentations at our conference. We are very, very grateful to this organization for helping us and for showing interest to collaborate with our society. So we hope that our collaboration will promote nutrition and nutritional science, and not only in our countries, but beyond. I'm very happy now to pass to Rusudan, our moderator, Rusudan Siklauri, and who will start the conference. Thank you very much.
Okay, good morning, ladies and gentlemen. I do believe that you all find very informative these 2 days. According to the agenda, a lot of important topics are covered and will be discussed. I'm very pleased that I have a chance, second time, to be a moderator of this international conference. You all can see that a lot of important topics related to the public health and nutrition is on the way to be present. Let's start with the first part of the day. The main objectives is nutrition as an implication of the public health. And let's start with the first presentation, which is comparing the health and nutrition status of the UK and Turkish population and examples of initiations to improve the situation. Please welcome Dr. Julian Stowell, Science Committee member of Sabri Ülker Foundation.
Perfect. Thank you very much. Well, günaydın to my Turkish colleagues, and good morning to everyone here. And for those online, it's good morning, good afternoon, good evening, and good night. So welcome. I'm going to talk about the comparison between Turkey and the UK, and much of what I'm going to say is based on a conference we had last year in Istanbul. But first I would like to say that there is a special bond between Georgia and England. St. George is the patron saint of both of our countries. And I believe that the motto here in Georgia is "Strength is in unity." which is a wonderful motto for all of us to follow. So going back to the conference from last May, which we held in Istanbul, it was aimed at healthcare professionals, and the idea was to inspire people to better consider the role of nutrition in achieving and maintaining good health. We call it healthcare through diet. And I'm proud to say that the proceedings have now been published in the British Journal of Nutrition, and hopefully everyone has a copy of that paper. And it's distilled out a lot of information, and the idea was that it should inspire people to think about health and nutrition and to act as a gateway for accessing further information. There's a huge difference between Turkey and the UK. Turkey is more than 3 times the size of the UK, and that's including Scotland, Northern Ireland and Wales, and yet the population is fairly similar. Turkey is more than self-sufficient in food, whereas in the UK we're importing over half of our food. Turkey is a younger population than the UK by about 7 years. So what's happening in the UK may well be happening in Turkey in years to come. Life expectancy is fairly similar in Turkey and the UK now. Of course, women live longer because they're better looked after than the men. And if you look at the healthy life expectancy, the difference between the UK and Turkey is actually less. It's less than 2 years. But there's an increasing discrepancy between life expectancy and healthy life expectancy. So what this means is that we're all looking at a life of chronic disease and disorders in later life, and it's getting worse. It's an unfortunate situation. I'm staring it in the face myself. In Turkey, the main causes of death are cardiovascular disease and cancer. No surprise, 70% of deaths are due to non-communicable diseases. Turkey has been rated number 1 across Europe in terms of the prevalence of overweight and obesity. And here the prevalence of obesity is higher in females. I couldn't really explain this until I thought that maybe a lot of the ladies in Turkey are kept at home and they're preparing food, and so they're tempted to overeat and not getting as much exercise. If one walks along the street in Istanbul, you hardly see any obesity. It's not the same in the US. You can't avoid it. You bump into it as you're walking along the street. But in Turkey, it seems to be less obvious. The prevalence of diabetes is absolutely shocking, over 14% of the adult population, which is a type 2 diabetes population of 9 million people. The increase over the 20 years from 6% to 14% could well be explained by better detection rather than just a genuine increase in the number of people with diabetes. Here's the numbers. Turkey, top of the league table. It's a difficult situation and expensive in terms of healthcare costs. So in terms of nutrition, the Turkish population, well, salt intake is said to be only double that recommended by the WHO, which is 5 grams per day. The current intake is about 12 grams per day. A few years ago, it was estimated at 18 grams per day. So Turkish food is quite salty, and I personally love the salty taste of Turkish food. Sugar consumption is said to be quite in line with recommendations, 30 odd grams per day. Saturated fat consumption, as elsewhere, is exceeding recommended levels. But there are several deficiencies in the diet that are still prevalent: iron deficiency, anemia, vitamin D deficiency, and iodine deficiency in nearly 30% of the population. And despite the fact that Turkey has an absolute wealth of fruit and vegetables available, they say that Turkey is one country in the world that has all 4 seasons at once, given the extent both in latitude and longitude, but there's still very low fruit and vegetable consumption. I can't explain it. And food waste has been estimated at 8 million tonnes per year. And the food waste is to a large extent waste of bread. The Turkish tradition is to buy fresh bread every day and then to throw it away at the end of the day. Whereas at home, I buy a nice fresh loaf of bread, and before I can cut one slice off it, my wife has put it in the freezer. So this is a tradition more in the UK than it is in Turkey. But I think the use of the freezer could well reduce food waste. I'm indebted to Professor Ilhan Satman, who is the professor of internal medicine at Istanbul University, and she's also in charge of the Turkish National Institute for Public Health and Chronic Diseases. And she's worked tirelessly over the years to develop strategies in terms of addressing the obesity issue and the diabetes issue. And a lot of work has been done. I can't really distill it out in the short time I've got, but there are lengthy documents with detailed proposals and strategies. I mean, here is the Healthy Nutrition and Activity Programme to prevent and control obesity. Physical activity has been mentioned a lot in the Turkish initiatives, which I think is very good. So there's been a lot of activities to improve awareness of the issues surrounding obesity throughout Turkey. Public service announcements, government websites, social media, events, competitions. It's been a really multifaceted program, and school training has been carried out both in cooperation with the local governments and the Ministry of Education and NGOs such as the one that I'm going to tell you about from our foundation. But the installation of cycle tracks has been an interesting one. Having been visiting Istanbul for 15 years, I've never seen a bicycle on any of the roads that I travel on, but I believe there are cycle tracks along the Bosphorus, and this is where people get their exercise. It certainly isn't intermingling with the traffic in Istanbul. That would be shortening life expectancy. There's quite a bit of legislation in Turkey to address the obesity issue, including restrictions on advertising to children, including restrictions on what food products can do or say, or where they can be positioned in supermarkets. It's quite an extensive and detailed program. And I won't go into all the details here. There's a school milk program. Well, when I was a boy, we had a school milk program in the UK because there was malnourishment, and it's nice to see it being revived in Turkey, where children are getting milk free 3 days a week, and also raisins in primary school children, presumably to improve their dietary fibre intake. And physical activity has been a feature of schools' education programmes. The Turkish diabetes programme looks to have been pretty well unsuccessful, but as I say, it's possibly a feature of better identification of type 2 diabetes and better ability to control it. But there are a lot of guidelines for clinicians and information available to the general public about how to address diabetes, but more importantly, how not to get it in the first place. Just a few words about Istanbul, which has a population considerably larger than that of Georgia. I mean, no one knows the population of Istanbul. It's possibly between 15 and 20 million persons. So obesity prevalence has been increasing, and the projection is that it will continue to increase, which I think is a very defeatist and sad projection, and I'm hoping it's going to be wrong. And again, there's more females obese than males, and considerably more morbidly obese females in Istanbul. That's with a BMI exceeding 40. And there have been some really interesting initiatives to try to address the issue of obesity in Istanbul, targeting school children, preschool children, and here we are. There's a project where 35,000 bicycles have been provided, and at 200 sport points, sports trainers are available between 7 and 9 o'clock in the morning. I can't tell you how much uptake there's been on that, but it would be interesting to have a discussion in the break on that, because I think it's a wonderful initiative. And of course the food plate is a focus of attention, telling us what we should be eating. But so how do we assess how successful these initiatives have been? It's notoriously difficult, and it will keep nutrition scientists and population specialists in work for as long as anyone can imagine. But here is a compelling graph that shows you what progress has been made in Turkey. In 1952, the average life expectancy was 41 years, and it's now gone up to 74. In the same time, the UK has gone up from 69 to 81 overall. So there's been some dramatic improvements in Turkey. I'm not saying it's due to nutrition, but it's due to nutrition, it's due to public health, it's due to the healthcare system, it's due to education, it's due to legislation. But it's a dramatic improvement, I think, that those involved should be proud of. And I want to just say a few words about the foundation that I've been working with since it was established in 2009. The Sabri Ülker Foundation was established in the name of Sabri Ülker, who was an entrepreneur and philanthropist in Turkey. He passed away in 2012, but in honor of his name, we established the foundation with a view to making a contribution to improving public health in Turkey and beyond. And I'm proud to have been associated with the foundation since the very beginning, although I suspect my days are numbered. So we are working under 3 pillars: education, research, and communication. And I just want to focus on one of our initiatives, of which we're extremely proud. And I'm hoping that very soon we'll have an English website going live, which will give you a much more detailed insight into the work we're doing more generally. But for now, let me just focus on the Balanced Nutrition Education Project. We felt early on in the life of our foundation that there's nowhere better to start than with children. And so we, at the beginning, collaborated with the British Nutrition Foundation and adapted a school education program that they have been involved in for many, many years called Food, a Fact of Life. And our colleagues at Hacettepe University in Ankara developed this program to be suitable for the Turkish population, and it was implemented in collaboration with the Turkish National Education Ministry. And the key message is that you can eat a wide variety of foods in a balanced way. It has to be nutritionally sound, balancing your energy input and expenditure, and combining that with a significant amount of physical activity. The program runs for 32 weeks in schools, from kindergarten now to 6th grade, and it's a 2-hour-a-week program with physical activity to begin every day, 10 minutes of jumping up and down, and you can see the enthusiasm of the students for that. And so far, we've reached approximately 7 million students, their teachers, their parents, their families. And we've tried to evaluate the success of the program, because people will say, well, that's all very well, but has it made any difference? And we've published some work on this. The total energy intakes decreased over the intervention period. Physical activity levels increased. BMI levels dropped for the female students only, and the frequency of obesity decreased for all students. And we're grateful to the 3 universities with whom we worked to conduct this evaluation. So now moving on to the UK, and I haven't got any idea how long I've been speaking for, because I think we're a little bit late, but I'll carry on until you just tell me to stop. Again, the main causes of death in the UK, cardiovascular disease and cancer, but the Office of National Statistics reported that dementia and Alzheimer's disease were the leading cause of death in 2022. That appears to be in conflict. But as we're getting older, we are suffering more from dementia and its associated complications. And I think what this attests to is that there's comorbidity between dementia and other chronic diseases. We are leading Western Europe in terms of our rank in the obesity tables. 36% of the adult population overweight, and a further 28% obese. So that's, you can do the maths, 60-something% obese or overweight. And in England, 41% of children are overweight or obese by the age of 10 to 11. Our diabetes rate is about 7.5%, of which 90% is type 2 diabetes. So we're not dissimilar to Turkey in many of these aspects. Energy consumption is significantly in excess of requirements, and those working on evaluation of energy intakes will know just how notoriously difficult it is to predict what people are really eating. How do you do it? Do you do it with food intake charts? The more people eat, the more they lie about what they're eating, I've been told. Not me, of course, but some people do. So it's difficult to work it out, but just to put it in perspective, if you just eat 250 calories a day more than you need for energy balance, that's equivalent to 11 kilos of weight gain per year if sustained. 20 kilos is 425 calories per day. Well, it isn't difficult to overconsume by that amount. Fat intake is okay, saturated fat too high. Free sugars more than double the UK recommendation. The World Health Organization said 10% of free sugars. The UK Scientific Advisory for Food, for Nutrition, came up with 5%, and I'll say a few words about that later. So we're at odds with the World Health Organization, but the achievement of 5%, it seems absolutely beyond anyone. dietary fibre lacking at all ages. Salt intake exceeds recommendations. I think 2 decades ago it was 9 grams a day, which the Turkish population would like to be aiming for. But now, after government campaigns, including some very bizarre campaigns using a snail, for some reason I don't understand, it's gone down to about 8.6 grams per day. And fruit and vegetable intakes are below recommendations at all ages. Now, we may be complacent about our position in terms of life expectancy, but this chart that I took from a recent edition of the Journal of the Royal Society of Medicine shows that the UK is slipping behind many countries, and we've gone from 7th in the World League tables back in the 1950s to 36th in 2020, 29th in 2021. And the country that has really bucked the trend has been Japan. And my wife was asking me why Japan is doing so well. Well, if you've ever been to Japan, you're fed on raw fish and rice, and it's pretty healthy, and the beef is superb, so that's possibly why. I took this slide from an early presentation I'd done years ago, and I looked up the citation, and I couldn't find it anymore. But this was a World Health Organization report from 2008, and they had estimated that up to 80% of cases of cardiovascular disease, 90% of type 2 diabetes, and 33% of cancer could be avoided by changing, and just under 30% of coronary heart disease and 20% of strokes in developed countries were due to the reasons why people are getting chronic non-communicable diseases are quite apparent. I mean, even the WHO doesn't predict that people won't have to die in the end, though everyone has to die, but it's best to die as healthily as one can. I'm indebted to Alison Tedstone, who was in charge of nutrition for the British government in 5 different iterations, from the Food Standards Agency through the Department of Health. She's now retired, but she spearheaded programs such as the sugar reduction, the salt reduction. She championed the Eat Well Guide, which has actually taken over from the food guide pyramid that was implemented in the US. And it's a simple guide to what we should be eating. And I myself have taken this guide into primary schools and shown them fruit and vegetables, and had a lot of interest and fun explaining to children how their diet might be improved. And I'm not going to go into the details of the diet compared with recommendations. I've given you a summary of that, and summary of the overconsumption of energy. But if you want to look into this further, then the information should be available from one of the hundreds of references at the back of the publication in the British Journal of Nutrition. So here's the sad story on obesity prevalence in adults in the UK. The graph speaks for itself, unfortunately. And here is the obesity prevalence in children. And that spike coincides with COVID, where actually taking physical activity was not so readily available to children. It remains to be seen whether this trend is going to be reversed in the coming years, but it seems to be a one-way street largely. Now, back in June, the government issued its latest plans to tackle obesity in England. To me, it doesn't look like a very well-integrated plan. They're targeting one or two measures, placing less healthy foods in stores and online, not allowing unhealthy foods, so-called, to be positioned near checkouts, although I always go for the peanuts when they're just while I'm queuing up to pay for my food. Introducing calorie labelling on menus in restaurants, I mean, that will really take half the fun out of eating out. I honestly don't want to know how many calories I'm eating when I go out for a meal. I'd rather not know, to be honest. The NHS has introduced, National Health Service has introduced a soups and shakes diet for people with type 2 diabetes, and I'll explain that in a minute why. They've announced several tranches of funding to explore new treatments, digital technologies, and school sports facilities to help children and young people have an active start to life. I think they're being a bit hypocritical here because over the time since I was a boy, most school playing fields in the UK have been built over with housing. So there's no longer anywhere for the children to go to take exercise. So let's see how it works out. Just focusing on sugar reduction for a minute, this has been a real push within the UK. And the basis for that, the evidence, was a report back in 2015 from the Scientific Advisory Committee on Nutrition, which is a really wonderful report, but it does make a compelling case that greater sugar consumption, free sugar consumption, is associated with a greater risk of a high energy intake. I mean, I've always been of the school of thinking that calories are calories, and whether you have them from sugar or you have them from fat or whatever you have them from, they'll have the same overall effect. But it does appear that there is association between higher sugar intake and the predisposition towards having a higher energy intake. So it's worth, that report is still valid, and there are a number of policy recommendations basically discouraging the advertising and the use of high sugar foods, portion sizes, having increased price for high sugar foods, and raising awareness in general. But one of the initiatives that Alison Tedstone is particularly proud of is the implementation of a levy on soft drinks, which came in 2016. So for anything that has more than 5% sugar in it, in terms of the carbonated beverage, there is a tax on it. It's been controversial. It became law in 2018, but the UK wasn't the first to think of this. I think Mexico was. They introduced a sugar levy in 2014, and they produced some compelling evidence that it has been successful. But to her credit, Alison has, and I borrowed this slide from her because it says it all, she hasn't been complacent about the success of this program. I mean, basically, sugar consumption over the period of implementation has gone up by 2.5%, but that is concomitant with an increase in the population of Great Britain. So no change in sugar purchased per person. But in terms of the foods that contain sugar, confectionery and chocolate has gone up considerably. At the same time, the sugar content of yogurts, cereals has gone down significantly, but most dramatic of all, the sugar levy has reduced the sugar intake in carbonated beverage by 35%. And of course that has been hand in hand with the increased use of intense sweeteners, which you may or may not like the taste of. My own view is that if people considered whether or not to still take sugar in tea or coffee, they should just sit there and add up how much sugar that means in the diet. It's a huge amount of free sugar going into tea and coffee. And I used to be one of the main culprits, but I decided to give up sugar in tea and coffee. And after 1 week, I couldn't bear the taste of tea or coffee with sugar. It was awful. So if anyone is still taking sugar in tea or coffee, they might want to consider a change. So just summarising Alison Tedstone's key points, the UK diet doesn't meet recommendations. It never has, but we always live in hope that one day it will. And current policies have had some impact, but certainly not enough. And the actual environment in which we consume foods is unhealthy. People point to the fact that people were eating a healthy diet during and after the Second World War, and that's because food was not generally available. It was on ration, so it wasn't left for us to choose what we wanted to eat. It was left to circumstances. So expanding food sales, there's a supermarket everywhere in the UK. You can't walk 10 paces without finding an outlet for food. You can't find a single town that doesn't have a Costa Coffee or a Burger King or, dare I say it, some of the other food companies that don't have a very good reputation. We have to go beyond information and education. And my wife's telling me that education is not the key to it. People know what they should be eating, but somehow they're not motivated. And next time, I think she should give this presentation because she's got a lot of good ideas. But we have to have deep and sustained structural intervention. This is what Alison is saying. I mean, she would say, because she was the head of the government that introduced a lot of legislation, but I believe she's right. Everything has to go hand in hand, and the politicians have to go more than just offering platitudes and words and hollow ideas. They have to actually put their money where their mouth is. I mean, Boris Johnson was not a good example of good nutrition, but it didn't take him off. Anyway, I want to end on a couple of really positive notes. Firstly, I want to just mention the direct trial, which I've mentioned also in the publication in the British Journal of Nutrition. It's a study that was organised by the University of Glasgow and Newcastle University in conjunction with Diabetes UK. And it took 149 participants who were recruited from GP practices in Scotland and Tyneside, people with type 2 diabetes. And they were given a 12-week intervention program of an energy-restricted diet, 850 calories a day, which is draconian by any standards, but once one gets used to it after a few days, hopefully it becomes more acceptable. At 1 year, 46% of all the people in that study were no longer type 2 diabetics. So they achieved a remission of diabetes by diet alone, but they had achieved at least a 15-kilo weight loss from an average starting level of 100 kilos. And at 24 months, more than a third of the people had sustained this remission, and whether they had or not was dependent on how much they had sustained their weight loss. And I want to just update you on that. Earlier this year was a 5-year review of where we got to, and a quarter of the people who were in remission after 2 years were still in remission after 5 years. So it's not a perfect solution, but it is compelling, and if people are disciplined and motivated, they can avoid medication. They no longer needed diabetes medication. And it was a compelling study. And then it's not the UK or Turkey, but Finland I have to use as my final example. I worked for 10 years with a research group in Finland. It's a small country in terms of the population, but a very well-educated population, and they had the worst record of premature deaths from cardiovascular disease among males. It was absolutely an epidemic, if you can use the word epidemic for a non-communicable disease. I think that's doubtful. But anyway, back in the 1970s, they launched a project which is now known as the North Karelia Project, which was a comprehensive, holistic approach to a healthy lifestyle. And it involved stakeholders from all aspects of society. And the intervention included improved nutrition, giving up smoking and increased physical activity. And hopefully reduced intake of vodka, which was the national drink among men. So here you can see that over the first 25 years of this program, there was an 84% reduction in premature death in males. Thinking about the US, the only state where obesity is not increasing is Colorado, and they have a program of physical activity. Anyone who wants it can get a pedometer to measure their steps, and there's a national weight control registry where anyone who's lost a certain amount of weight and keeps it off for a year registers on this program, and that's quite convincing, but it hasn't been extended to the rest of the US. So my final remarks, I think in both Turkey and the UK, life expectancy over the last 75 years has increased. But even now I'm personally living on borrowed time because we don't live forever. The increase in Turkey has been dramatic, but healthy life expectancy isn't increasing now. And people are saying that our children will live less of a healthy life than we are. So it may have turned the corner. We really hope not. So it means that our populations are increasingly living with chronic disease and disorders, and that puts a burden on the healthcare services, such that in the UK, the healthcare system, the National Health Service, which has been an example to the rest of the world, is virtually broken. My 98-year-old mother was going to be sent to hospital last week. She'd had a serious incident, and the paramedics who came said, well, we could take you to hospital, but you'll be waiting for about 5 hours in the ambulance before you can get a bed on a trolley in the accident and emergency department. It's best for you to stay at home. It's shocking, but that's just one example. So there are many initiatives underway to improve the situation, and some have been inspiring, and there have been dramatic improvements, and there's much still to be done. But a holistic approach is essential. It's not only education, it's government authorities having a sort of light touch, but implementing legislation that is going to help people point themselves in the right direction. But at the end of the day, we've all got to take control of our own destiny. We can't blame someone else for the way we are. We are the way we are because of our own ability to control our destiny. And we're really hoping that this week's conference and workshops will lead to new initiatives in Georgia and beyond. And I'm looking forward to the discussions. And strength is in unity. So thank you very much for listening. So, thank you. No questions, I guess.
I Okay, so thank you for the meaningful presentation, Dr. Julian Stowell. I think for the question and remarks, we have a special time during this day at the end. So if someone has a question, please wait a little bit. I think we agree that obesity is a main challenge of not only for UK or Turkey, but for all the rest world. And the obesity will be the main topic for the second presentation of today. Please welcome Professor Dayan Banati, Vice Dean of the Science University of Szeged. And the title of the presentation is The Obesity Epidemic in Europe.
Dear Chairman, distinguished guests, ladies and gentlemen, this is a real pleasure to be here in Tbilisi today in this wonderful city. And although I didn't understand a word of the opening, but I picked up konferencia, delegácia, and Sabri Ülker. So once again, it's a pleasure to be here, and I'm going to talk after Dr. Stowell's excellent presentation about obesity, and the presentation is entitled The Obesity Epidemic. And that's true that we usually do not use the term epidemic for non-communicable diseases, but for communicable diseases. However, there are threatening data. The prevalence of obesity is really thought-provoking and sounds threatening. In general, non-communicable diseases, at least in the European region of the World Health Organization, there is a very high burden and a sharp increase over recent years worldwide. In 2021, non-communicable diseases caused 90% of all death, and 85 of years lived with disability. The most affected region of the World Health Organization is unfortunately the European region. Overweight and obesity together are the fourth most common risk factors for non-communicable diseases. The first one is high blood pressure, the second one are dietary risks, the third one is tobacco, and the fourth is overweight and obesity. On the next figure, you will see the trend regarding years lived with disability due to non-communicable diseases. So what you see is the years lived with disability per 100,000 citizens for both sexes, and all ages are included. The data are collected by the University of Washington, the Global Burden of Disease Center. This is a center which is joined by numerous international organizations, and they all provide data which is transferred and shared publicly. So on the graph on the very top, you see the USA, then Germany, then Japan and Australia. So there is an increase in number of years lived with disability because we suffer from non-communicable diseases. We all know that obesity is very complex. It's a complex multifactorial disease, one may say. This is defined as abnormal or excessive accumulation of fat, and it is a very serious public health challenge globally. Major determinant of disability and death, and it is measured through the BMI in kilogram per me too. So what I'm going to show on the next figure are the numerous different medical conditions which are associated with obesity, like chronic respiratory diseases, non-alcoholic fatty liver disease, chronic kidney disease, excuse me, diabetes mellitus, cardiovascular diseases, mental health problems, and there are 13 different types of cancers where the excess body weight would increase the risk of developing those cancers. The latest data regarding obesity and overweight are provided by the World Health Organization. They have a very interesting and very heavy report on obesity. They focus on their European region, and they provided data for 50 countries of the 53 involved. So as I mentioned, obesity is a key risk factor, and it affects 60% of adults. I think it's horrible to see such high figures. 63% of men and 54% of women. And more than 50% of the adults are overweight, obese or overweight in 50 out of the 53 member states, at least in the European region. And what is even more worrisome, that 1/3 of children, 29% of boys and 27% of girls on average belong to this group. And under 5 years of age, almost 8% of children are affected. Overweight and obesity together cause more than 1.2 million deaths in this region. And they cause 7% of total years lived with disabilities. There are some specific aspects regarding COVID-19 pandemic. We already know that overweight and obesity link to greater morbidity and mortality from COVID-19. There were severe outcomes, including intensive care unit admissions and deaths as well. The prevalence of overweight and obesity increased in children and adolescents during the pandemic. And according to different and very interesting studies, there was an increase in the consumption of those kind of foodstuffs which are high in fat, sugar, and salt. At least that was observed by these research teams during the COVID-19 pandemic. What sounds quite surprising, especially having the Mediterranean diet in mind, that the highest levels of both overweight and specifically obesity are found in Mediterranean and Eastern countries, where more than 60% are affected in both sexes. The following countries: Turkey, Malta, Israel, UK, Andorra, Greece, Czechia, Bulgaria, Spain, Hungary, and Ireland. So in these countries, more than 60% are overweight or obese, and in Kyrgyzstan, Uzbekistan, and Tajikistan, less than 50%. So the difference is quite huge. On the next figure, you will not be able to read the name of the countries. I will pinpoint some, but I just wanted to show you in general the percentage of adults being overweight. So we will focus on overweight, including obesity. And what you see here, that on the top there is Turkey, followed by the United Kingdom, then unfortunately Hungary. That's the country I know best. This is the average of the old EU member states, then the average of those member states who joined in 2004 the European Union. And here you find Georgia. So I don't know whether you can be proud of this data, but at least you are in a good position to try to prevent what is happening in many other countries. So probably this is still a good time when you can focus on public health literacy, nutrition literacy, and try to provide evidence-based, easily understandable information for the population in order to make them understand how to prevent to have overweight and to be obese. So, as I said, the highest level of both overweight and obesity are found in Mediterranean and Eastern countries. And when focusing on obesity, but because in the first slide you did see overweight, now we will focus on obesity. So more than 25% of the population is affected in Turkey, Malta, UK, Hungary, Lithuania, Israel, Czechia, Andorra, Ireland, Bulgaria, and Greece. And those countries are listed on the bottom where less than 20% of the population is infected, like Azerbaijan, Denmark, Switzerland, Moldova, Turkmenistan, Bosnia-Herzegovina, Uzbekistan, Kyrgyzstan, and Tajikistan. Now I'm going to show you a similar figure like the previous one. So here you see, unfortunately, again, Turkey on the top, followed by the United Kingdom and Hungary, and here, somewhere in the middle, you will find Georgia. So where in between 20 and 30% the population is affected. So we have experienced a rapid increase in the levels of obesity and overweight amongst adults. And the recent prevalence estimates for overweight, including obesity, that 10 years before 2016, the increase was 8%, and since 1975, the prevalence has increased by 51%. And in terms of obesity, before 2016, the decade before, there was a 21% increase, and since 1975, it's quite shocking, the obesity rose by 138%, the obesity rate. So this is definitely a very great concern in the European region of the WHO. If you wanted to see the trend in case of obesity, including, overweight, including obesity, among adults in the countries of the WHO European region, and you would see here where the red shows data for both sexes, the blue line for male, and the green for female. So this is the trend for overweight in between 1975 and nowadays. And on the next figure, you will see the same for obesity. So both sexes, female, male. Again, since 1975. What I'd like to draw the attention to is early life, because unhealthy body weight in early life can affect a person's tendency to develop obesity. So obese children risk to be obese at adult age. It is definitely a common problem, and according to WHO's estimates, 4.4 million children under 5 years of age are affected. They are overweight. And that represents, as I already mentioned at the beginning, almost 8% of children who are younger than 5 years. This data comes from a UNICEF WHO World Bank joint study. On this figure, what you will see is the estimated prevalence of overweight, including obesity among children under 5 years of age. I will show different age groups. And here you see Georgia, somewhere in the middle. So in between 5 and 10%, approximately 7.5% rate, so in children under 5 years of age. And on this figure, we focus on 7 to 9 years old children. On the left, you will see data for boys. On the right, in green, for girls. The lighter part is always referring to overweight, and the darker color shows obesity rates. So, again, you see, you see Georgia, Hungary. So here you see the figures. And I wanted to point out that some of those countries where they are supposed to follow Mediterranean diet, like, for example, Cyprus, you see, overweight data. Greece, again, overweight data. Italy, Malta, and Spain, here, in these countries where one would expect a lower rate of obesity, in these Mediterranean countries, they have quite shocking figures. So the prevalence of overweight and obesity increases in the age group of 5 to 9 years old children. 1/8 of children approximately, so more than 11% live with obesity, which means that nearly 1/3 are overweight. In the age group 10 to 19, there is a temporary slowdown, I would say. So the obesity and overweight rates are not increasing, but then later on this may change again. What I would also like to point out that the prevalence of obesity and overweight among males between 5 and 19 years increased almost threefold in between 1975 and 2016, and doubled in female teenagers, if you like, children and teenagers. Here you see prevalence of overweight and obesity among children and adolescents aged 10, 19 years. Here you see data for the UK, for Turkey, for Hungary, and for Georgia, this one. So once again, you are in a much better position than several other countries. So this is time to act. As I already pointed out, childhood obesity is quite a problem all over the WHO European region, and there are numerous causes, low or no breastfeeding, for example, availability of cheap and unhealthy foodstuffs, intensive marketing, digital marketing towards children. Now there are discussions in some countries not to allow direct marketing of unhealthy foodstuffs for children during daytime. Poor quality school provided in schools, not too much physical activity, low health literacy, as I already mentioned, and limited financial and psychological resources. So how about policy? Why shouldn't policymakers act? They do, they seem to. At least there are different action plans, programs. So, for example, one of the Sustainable Development Goals of the United Nations, namely SDG 3, ensuring healthy lives and promoting well-being for all people at all ages, is a very important one, but this is already clear that we will not reach the target. There are numerous policy frameworks. I'm not going to read out all, but mainly from WHO, European program, childhood obesity programs, etc., etc. Still, public health systems are failing to slow increase in different risk factors. The reasons are numerous: environmental, societal, psychological, the food environment, cheap food, heavily promoted unhealthy foods are highly accessible. There are heavy subsidies. This is why sugar is relatively cheap. Generally, the focus is on economical growth for different countries. The markets are liberalized. There are fast food restaurants. In the same time, food deserts where there is limited access to healthy and affordable food. The food marketing, as I already mentioned, the obesogenic digital food environment, social media, bloggers, influencers, and let's not forget there are other factors which should much better be studied and researched. For example, the influence of endocrine disrupting chemicals as obesogens. So we already know that they can influence both appetite and weight regulation, but probably we do not yet know enough about this kind of risks. So WHO had already stated a long time ago that our diet is closely related to different diseases, oh sorry, the other way around, different diseases are closely related to the way you eat. So 41% has a strong correlation to non-communicable diseases, and in most cases what and how we eat is somehow related to our health. We also know from different data that despite the advice, the population, both adults and children, do not eat healthily. They do not have a balanced diet. They do not eat enough vegetables and fruits. And it's shocking to see that the proportion of those adolescents who do not eat fruit and vegetables on a daily basis is very high. So data for Georgia is provided here. This is, it says England, United Kingdom, Hungary, for example. This is quite shocking that in some cases 50–60% of the youngsters just simply don't eat fruits and vegetables on a daily basis. Of course, amongst all the factors, the socioeconomic changes are remarkable. We are doing our shopping in a different way. There are promotions. We tend to buy much more food than what we need. We sit in front of the computer, no physical activity, advertisements. We even eat in front of the TV and the computer. So I just wanted to point out that there are physical obesogenic environments and obesogenicity of digital food environment should also be taken into account. I'm not going to through all the factors, but to pick up a few, I already mentioned the way we are shopping, so we buy big quantities, and the behavior of consumers is one of the most difficult things to change. That's also important to mention. The portion size is much bigger than it used to be. Snacking all day, and we got used to sweet food. The information overflow and all the information which is provided by the media and not science-based, not evidence-based, has an influence of people who mainly get their food-related information from the internet. That's what different publications show. And I just like to point out a conclusion of one of the studies which came to the conclusion that the low-fat trend initiated by government guidelines in America in 1977 and in the UK in 1983, without sufficient evidence from randomized controlled trials, resulted in almost 30 years of public policy advice that had no merit. I mean, this is a very heavy conclusion of a study, but besides the media victimizing certain type of foodstuffs, there is no easily understandable, clear evidence-based advice from reliable sources which seem to get to consumers, which seem to be understood by consumers. According to another study, they analyzed the information provided by so-called health food bloggers. And they also noted that 80% of adults in the US and almost 70% of adults in the UK seek information regarding their health online, mainly online. And without going into details, let me just show again the conclusion they ended up with, that the advice that the health food bloggers offered was not evidence-based. I think it's one of the most important conclusions they ended up with. So as I already said, health literacy is very, very important, and as WHO stated last year, it is an unrecognized obesity determinant. And amongst all media outlets, not surprising that consumers sometimes just have no idea who to believe. That's why it's so important that nutrition societies, dietetic associations become a good source of evidence-based information. And if some of you just had in mind other solutions, like why not through food labeling, for example, I have no time to go into the details, but all the debates regarding food labeling and Nutri-Score, Keyhole, or any other system where with good intention we try to provide information for the consumers about the healthiness of the foodstuffs, I mean, we take off the responsibility from their shoulders, because they were supposed to see only the color. Oh, this is not red, not green, but orange. Okay, still acceptable. I mean, it's just too much simplifying things. So no surprise that there are so many discussions going on. And the dietary guidelines. We make good use of the dietary guidelines, and EFSA, the European Food Safety Authority, stated a few years ago that it is not possible to provide unified dietary guidance for all citizens, for all consumers. I mean, we live in very different cultures, we have very different food environments. Still, what I wanted to point out, although some of them I really like, some Asian ones, but what I wanted to point out, I used to live almost 7 years in Brussels, and as you know, there is the French and the Flemish community. But come on, they live in one country, and their culture is not that different. Still, there are huge differences in the recommendations, both what they put on top and bottom, both regarding the quantities. So cannot we provide sufficient nutrition advice? We can. If you see the very simple rules from FAO, I mean, it's so easy to list how to eat. Eat plenty of vegetables and foods, fruits. Watch your intake of fats. Cut back on beverages high in sugar, etc., etc. So these are extremely simple rules we should already teach to all children, even in the kindergarten. So this is a complex problem, and I don't have more time to go into detail, but I would just like to finish my presentation with something what a friend of mine saw in Brussels. Luckily, I was already back home in Budapest during the COVID, but she sent me a picture from a supermarket shop window full of chocolates. You know, there are really good chocolates in Belgium. And they said that do a COVID test, eat chocolate in every half an hour to make sure that you still feel the taste. So thank you for your attention.
Thank you, Professor. You give a lot of stuff to think about during the day and not only. Now it's time to welcome the Georgian presenter to see what's happening here in Georgia. The presentation is about nourishing Georgians' future, assessing nutritional status and empowering healthy choice amid Western influence. Please welcome Eka Bobokhidze, who is Associated Registered Nutritionist, Georgian Nutritional Society member, and PhD researcher from University of Reading.
Good morning, almost good afternoon, because we're a bit behind of our schedule. It's my pleasure to be presenting in front of you today, and I'm very happy to see so many of you from different backgrounds, and I'm very, very happy to see your interest, increasing interest from year to year. I'm welcoming our Turkish guests and our international guests. I'm very happy to finally meet you in person. And today I'm standing in front of you as a Georgian Nutrition Society's board member, but I'm also a PhD researcher and will be going to the University of Reading very, very soon. And I'm very happy that I managed to present to you before I left. So let's start the presentation. So in the following presentation, I wanted to talk to you about nutritional intake data that we face quite an important challenge as a country. I also want to cover a few trends that we know of that are currently happening in Georgia. I will also cover some adverse health effects of dietary trends discussed throughout the presentation. And I would also like to talk about a little bit of our current food environment, especially in urban settings, that hugely impacts our day-to-day dietary habits. And finally, I have a small call for action for our audience, because I believe that we all share common responsibility to do something and to help Georgia's nutritional situation. So a very short introduction. This is mainly aimed for our international visitors, our guests. This is Georgia, and we call it Sakartvelo, first Georgian word from my presentation. This is a population based on the Statistical Department of Georgia, and this is an estimated amount of food that we consume each year. This number is a very, very rough estimate, and I do want to declare that it might include some food waste, but this is a statistical, numeric showcase that we really do consume and live around the food each day, every day, couple of times per day. This is what Georgian cuisine looks like or might look like. It might differ, and I hope our international guests had an opportunity to try a few of Georgian dishes, and hopefully you will have opportunity to try even further. So I wanted to give you another Georgian word. This is supra. This is a very specific word that we call Georgian table, that we place all the dishes and all the food that we present to our guests. We are very, very proud of our cuisine because it's very unique. It's a mix of European and Asian dietary cultures. But to give you a small overview what it might look like or what it historically was like, especially western part of Georgia, it was very, very rich in vegetables and fruits, more like Mediterranean type diets. But nowadays, it's not as much like as Mediterranean diets, unfortunately. Because as a country, we thrive, we want to be closer to Europe, to Western culture. And as much as this is good, as we want to develop and go further and further, Western dietary culture has brought us many challenges and changed our dietary behavior and our culture specifically. I had a huge thought about it. I didn't want to start with challenges in the beginning of my presentation, but I couldn't avoid this theme because it's very, very close to my heart as I worked on this subject for years. And it is without denying that having nutritional intake data is utmost importance for each country, but especially for Georgia, and I will let you know why. So to give you a brief introduction, we don't have any nutritional intake data. The last time the study was conducted, we were still part of Soviet Union, so you do the math how many years has passed. Since that time, a lot of things have changed and a lot of huge dietary changes have been present in Georgia. So we really need to know what our population is and how the dietary trends look like so that we calculate the further interventions and further steps to help Georgia stay healthier and live longer. I want to thank Dr. Ketevan Dadiani, who is present here today with us. And I'm saying her name because she was leading the project. She created this huge project for Georgia, which is about nutritional intake data. It was planned as a nationwide nationwide study, and the end goal, the main objective was to collect nationwide complementary data about nutritional intake. We could use that data for various reasons and for various goals, but primarily, specifically, this project was aimed towards food safety measures and food safety risk assessment procedures. However, the data that would be collected through this study could have been extremely useful for various directions of public health. Here you see different aspects of research methodology that was included in the project as such, and I would like to share some progress that we made through a year and a half that we were lucky to be working on this project. So, as I've mentioned before, Georgia is nothing like Europe nor Asia, but it's rather a mix of both cuisines. And as I also mentioned, this such type of study hasn't been done for ages, for decades, couple of decades. So we had to start from scratch. We took a methodology of EFSA, European Food Safety Authority, as was recommended because we aimed to conduct this study for food safety measures. But we had to adapt this methodology because cultural norms and cultural aspects of Georgia is quite different and required some great modifications to be relevant. So we created nutritional intake data for locally produced products, food products, because we didn't have any data that was valid nowhere in the world. We had an opportunity to do some lab tests for locally produced dairy and various types of dairy products, and we included all this data in our nutrition database. We also worked on the most popular local dishes. We standardized their recipes so that it would be easier during the field trip to make calculations and to receive the data from people. So immense work has been done. I mean, I've been talking about this for 5 minutes or even less now, but we've been working on it for more than a year and a half. But unfortunately, very sadly to us, this project is on hold now. Despite of the progress that we made, you may all be well aware that such kind of studies require a lot of financial support from government or from our international agencies, partners, and because we couldn't have that financial support, we had to put the project on hold. And we really, really hope that this project will address well-deserved attention and will be continued very soon. And we've had a lot of discussions with Parliament, with various ministries, various donors, etc. But it's time-consuming, and we won't give up, I think. So why do we need nutritional intake data overall? I mean, it's not only statistics, it's not only numbers, but it's a map that would guide us through these enormous woods and would help us to prevent non-communicable diseases even better. Imagine if you were doing a puzzle, but you were missing a lot of pieces. It would be impossible for anyone to have a whole puzzle without having all those pieces. And nutritional intake data is such kind of piece that we extremely need to not to act blindly in this sphere. So what data am I presenting to you now if we don't have nutritional intake data? We have a few studies that were conducted by our international partners, organizations, WHO and USAID, and lots of other partners that we have, gladly. And STEPS study was one of them that was conducted twice in Georgia in 2010 and then in 2016. The third intake was planned to be conducted in 2021, but because of pandemic, it was postponed, and I don't know when it's going to be conducted anytime, if it's going to be anytime soon or not. But the results that we have is alarming, if I may say so. But to give you, before we go to the results itself, you see here some research characteristics about STEPS study, what kind of data they collect, and how many people from Georgian population they recruited. So this is one of the alarming results, dietary trends that we see in STEPS study, especially the second intake that was conducted in 2016. I put red arrows here. I think all of it deserves to be with red arrows, but a few of them I put in here. So I wanted to pay attention to fruit consumption and vegetable consumption. Average consumption is quite low for both sexes, but if you pay even further attention, you might notice that each dietary trend, males are doing a bit worse, if not much worse than females. Further, I want to highlight some salt intake data that we also had from this STEP study. So it was estimated that around 8.5 grams per day was an average salt intake for Georgians. Again, males have a significantly higher intake of salt compared to women. And I put here also a cardiovascular health risk from the same study to make a connection between those two dots, because we all know that salt consumption is correlated with higher risk and higher prevalence of cardiovascular health, and this study also highlights that result. So a good news here, not only bad things happening, but good news here is that Georgia is actively working with WHO's regional office at the moment to have nationwide salt reduction policy. It's under construction at the moment, and hopefully we will see it very soon, and hopefully it will help us to reduce salt intake anytime soon. Further, adverse health effects that were highlighted in the STEP study that shows us where we stand as a country and what situation do we have. They also measured some body mass index, for example, and grouped the results by age and sex. If we look here, the results are not as good. Some countries in Europe have higher prevalence, of course, but it's still not good, of course. And I want to summarize STEP's outcomes and main risk factors that they outlined in this study. So the main point of this study is that almost the whole population, almost 92%, more than 92%, were under at least one influence of at least one or more risk factors that are outlined here in this blue box. And more than a third of the population were influenced by 3 or 5 risk factors that were studied in this study. We also have to pay attention that men are more influenced by these risk factors. This is alarming because we see some health disparities in this result, and we might need to take this in account when planning health interventions or health policies. And almost half of the population had a high risk of at least one non-communicable chronic disease. Another study that I brought today is Feed Cities study project. This is a very specific study that looks at the food environment, especially in urban areas, and they studied Tbilisi as it is the biggest city, the capital in Georgia, and most of the population, almost half of the population, is located in Tbilisi. So it's extremely important to know what the food environment looks like in Tbilisi and what determines main dietary habits that we have to conduct each day. So based on this study, they highlighted that there is limited availability of fresh fruits and vegetables around the city. They also highlighted that there is also very limited availability of non-sugary drinks, whereas sugary drinks are highly available and easy to buy for children and adults also. They also highlighted that main food vendors that are available all around the country. They sell foods that are high in salt, sugar, and trans fatty acids. These three are our main enemies in this case, and we have all of them in our fast food industry altogether. So this study gives us idea that we need to take action against urban area, against food environment that is present currently in Tbilisi. Because food environment extremely affects our availability, the availability of food, also accessibility, affordability, and desirability. If we see food, it's hard for us to make healthier choices because everyone in Tbilisi is hiring somewhere. We are always lack of time, and lack of planning also doesn't help in this matter. So here is a call for action. Of course, this is not mandatory steps, and we do not have to take them step by step or all of them, but this is just a recommendation or guidance that we might consider that it might help us to make better choices and help our population make better choices every day. We need data collection, so we need to collect data, and we need valid data that will help us make better interventions, evidence-based interventions that will be cost-effective and give us better results. We need to make a lot of noise about nutrition, healthy diet, but this information should be evidence-based, of course, as mentioned previously in previous presentation. Policy initiatives that are quite lacking at the moment, but it is not surprising as we don't have any valid nutritional intake data, and it's really hard to plan them ahead blindly. We are desperately in need of education programs, especially higher education programs, bachelor's or master degrees. And we know that there is a high desire among students, among youngsters to know more, to learn more, but there is no available accredited bachelor's or master degrees at the moment in Georgia. We need to help the community, the public, to be more engaged, and if they know more, they are more willing to nudge policymakers and food producers to give them healthier options, to give them healthier foods. So we might consider to include people in this process. We would also like to collaborate with our stakeholders because this is a huge war and we wouldn't make any success without any help from outside, and especially if the helper is experienced and knows more than us. We might also consider incentives for healthier practices, especially business operators who already produce healthier options, and we know some businesses who do so in Georgia, and we might consider helping them be more successful, reach more people, and produce more and more food products. And finally, a continuous evaluation of the process and take actions before everything goes wrong. This is, of course, a cycle that will go endlessly, and we all might consider to be a part of it. As a Georgian Nutrition Society, we think that we are doing some contribution towards this huge issue. Since 2018, we've been advancing nutrition in Georgia, and we've been conducting international conferences with help of our international colleagues from the United Kingdom. And this year we are welcoming our Turkish colleagues, and we're very happy about it. We also want to make international knowledge about nutrition more accessible and affordable to Georgian population, and we are really working for it very hard. I know this knowledge of English might be an issue for some, and we also are thinking about translating some of the webinars so it's more accessible and affordable for bigger audience. We also aim to promote nutrition across various industries, not only public but also business operators, also policymakers, health professionals, influencers even, because we all have our part and we all do our jobs in this area. We also are partnering with some healthy food producers. Some of them you might see here that we are very proud to be partnering with, but we also have some partners that are not present today, sadly, but hopefully we will have an opportunity to introduce them to you next time. Thank you very much for your time. It was a pleasure again, and I think it's great. Yeah?
Okay, thank you, Eka. Now it's time to have a little bit stretch and have a break, coffee break, 15 minutes. So we are inviting you upstairs. Please take all the information with you about sugar intake, obesity, and have a great coffee break.
Hello, John? Are you there?
Hello.
Hi, I'm sorry we're so behind. Um,
That's okay. I got the message from
uh,
Renata.
oh,
Thank
that's
you.
great. That's great. I couldn't text you because I was presenting myself. So, are you ready to test your presentation if it goes well?
Absolutely. And by the way, Eka, I heard the final part of your presentation. You did a great job.
Thank you. Thank you so much. Thank you. So, could you share your screen?
I'm going to try doing that now. Just a second.
Okay, thank you.
Can you see that?
Let me double check with tech team, please. Just a second, John. They're checking something.
Okay, that's absolutely fine.
Yeah, thank you. I think we're gonna need a moment, John. I'm sorry.
That's perfectly okay.
Okay. Okay, John, we see you perfectly, and your presentation is also.
I'll just try moving on to the next slide to make sure the...
Yeah, yeah, please go ahead. Yes. Yeah, yes, we see the second slide now.
Okay. Shall we move on? Yep.
Yeah, perfect. Yes. Yeah.
Good. So
Amazing.
technology is all right.
Yeah. Thank you. I think. Um, ზემოთ კუთხეში რა ინფორმაცია იქნება ისეთი, რომ John, can we try again, please, to go to the next slides?
Okay.
One more, please. Yeah, yeah, great. Thank you. Thank you.
아, essa dá 1 minuto, Jones. 처음으로 가이 상부터. 오늘 가이 상부터 기다려.
John, so we're on a break now, and we're going to need a few minutes until people are back. But we're all ready.
What time do you expect to start?
In around 10 minutes?
Okay, that's
Yeah.
absolutely fine.
Okay, great. Thank you.
Thank you very much.
უკაცრავად, მე მგონი დროა რომ დავიკავოთ ადგილები, please. Find your seats. კიდევ ერთხელ გთხოვთ რომ დაიკავოთ ადგილები, რომ დროში ძალიან არ ჩამორჩეთ. If we want don't to be behind on time, so please have a seat. Okay, so after a very lovely, a little bit windy coffee break, it's time to continue our conference. And we have two very interesting presentations ahead before the lunch break. The first presenter is online. Professor John Mathers, Human Nutrition Exercise Research Center, Faculty of Medicine from the Newcastle University, UK, will present a topic about global challenges for nutrition and health. Professor, can you hear us?
I can. Thank you very much.
Thank you. The floor is yours.
Thank you very much for that kind introduction. And I'm delighted to be able to have the opportunity to contribute to this important conference. So in my presentation, I'm going to present the challenges for nutrition health research in a global context. And this is the way in which I've structured the presentation. I'll begin by making some general comments about the importance of nutrition for good health, and then I will look at the two sides of the nutrition question. First of all, undernutrition and then overnutrition, focusing particularly on obesity and obesity-related conditions. And finally, I'll talk about interventions, what we could do to make a difference and to improve nutrition and improve the health of people across the globe. So to put this in context, nutrition really matters in terms of our health. And in a typical year, poor diet is responsible for about 11 million deaths. And in addition, there are about 250 million disability-adjusted life years, and that's a well-recognized measure of morbidity. So poor diet is contributing not only to premature mortality, but also to a large global burden of poor health. So these data from the Global Burden of Disability Consortium show the contribution that different components of the diet make to mortality. On the left, you can see that as deaths per 100,000 of the population for different types of country around the globe. So diets containing too much sodium, for example, have on average the highest contribution to mortality. But many other aspects of the diet also contribute to poor health and risk of premature death. And on the right-hand side, you can see the main causes of those premature deaths. And they include cardiovascular diseases, type 2 diabetes, and cancer. And in the yellow box, I've made the comment that these estimates are likely to be underestimates. So the real total contribution of poor diet to mortality is likely to be greater than what we see here. So I've been talking about mortality, then here are the equivalent data for morbidity. And again, poor diet is contributing to high rates of morbidity across different income groups across the globe. And again, most of that morbidity is associated with obesity-related diseases, cardiovascular diseases, type 2 diabetes, and cancer. But as I said at the beginning, I want to look at both sides of the equation, the so-called double burden of malnutrition. And I'm going to start by looking at undernutrition, and particularly at the lack of micronutrients, vitamins and minerals. And on the screen now, you can see very recent data published just last year on the prevalence of micronutrient deficiency among non-pregnant women of reproductive age, so between the ages of 15 and 49, in a number of countries. The data are shown according to the type of micronutrient deficiency. So the colored bars, for example, are for vitamin D deficiency, deficiency of vitamin B12, or folate, but also for iron and zinc, and for vitamin A. And in the gray part of the bars is the prevalence of women with at least 2 micronutrient deficiencies concurrently. And the rates are very high. You can see that in some countries, these are 80% or more of these women of reproductive age suffering from micronutrient deficiencies. And the problem is not restricted to the less wealthy parts of the world. I put in the red box the data for my own country, for the UK, and you can see that more than 50% of women in this age group have micronutrient deficiencies. And if you turn now to preschool children, data are organized in a very similar way, and again, the rates of micronutrient deficiency are high in many parts of the world, 75 or 80%, for example, in Cambodia, Cameroon, and India. So micronutrient deficiencies are common around the globe. And that means we need to pay more attention to improving nutrition among the vulnerable groups, particularly women and children, but it applies to the whole population. And that is because undernutrition drives a whole range of other problems. There's a very close relationship between nutrition and immune function, and if one is undernourished, the immune system works less well, there's a greater risk of infectious diseases. Those infections drive a whole range of other problems, for example, poor respiratory function, dehydration, reduced cardiac function. And when all of those conditions exist with poverty and poor access to healthcare and social support, then that drives greater mortality. And this is a vicious cycle. So we need to break the cycle by improving nutrition. And that applies to diseases that are still very, very common. And I'm going to give you one example for tuberculosis, or TB. So in a typical year, more than 10 million people get TB, and more than 1.5 million people die from this infectious disease. And so it's really important to change public health to reduce the risk. And very recently, there was an excellent study published from India showing the power of improving nutrition in lowering the risk of TB among poor people in India. Here you're seeing in the slide the incidence of TB among the control group, who are in red, and the intervention group, who are in blue. And you can see that over time, the two lines separate, so that the hazard ratio among those in the intervention group is reduced by 40%. So a very simple intervention of providing extra food and a micronutrient supplement for 6 months reduce the risk of TB among people exposed to TB because of people with the disease in their household, really big improvement in lowering the risk of TB. So showing again the importance of improving nutrition. To emphasize again this close relationship between nutrition and immunity, and we've seen that again in the recent COVID pandemic, when again there was a renewed interest in understanding how components of nutrition influence immunity and might protect us or help to protect us against a common infectious disease. Let me turn now to the other side of the malnutrition problem, and this is overweight, obesity, and the risk of non-communicable diseases such as heart disease and diabetes. So overweight and obesity are very common, and in this map you can see the prevalence of obesity across the globe. And the data are arranged so that as the colors move from purple to yellow and then brown, you're getting higher and higher incidence of obesity. And you can see this is spread unequally across the world, with very high rates of obesity in many parts of the globe. And obesity rates are changing rapidly. And I'm going to show you some data, first of all, for China, and then for India, the two most populous countries in the world. And these two countries have been undergoing a major economic transition over the last few decades. What you see here in blue is the distribution of BMI in the population in China in 1993, and then in brown, the distribution in 2015. So in just over 2 decades, there's a major shift to the right in the BMI of people, of adults in China. And that translates into many more people with obesity. In this plot, obesity is defined in a number of different ways. But if we just look at the blue lines, which are using the WHO definition, what you see here is a 4-fold, a 4 times increase in the rate of obesity between 1993 and 2015. That is a massive change. If you now move to India, and what the map shows you is the prevalence of obesity in the different states within India. So the lowest prevalence is in green and the highest prevalence in red. And the highest prevalence is where more than 25% of the population is living with obesity. And you can see that major parts of India have more than 25% of the population living with obesity. If we then look at people in urban areas, which is in the top figure on the right, you can see that in every single state for which there are data, except one, the mean rate of obesity is above 25%. That is really striking. And even in rural areas, which are at the bottom, you can see that the rural population of some states in India have now reached 25% obesity prevalence. So these are dramatic shifts in the rates of obesity as India has gone through this economic transition. And it's not just adults, we see the same thing for children. So here are data for 4 countries: Ethiopia, India, Peru, and Vietnam. And we have data here for children between 5 and 15 in both urban areas, shown in the blue lines, and rural areas in the red lines. And you can see a rapid increase in the mean BMI among these children in all 4 of these countries. And although the rates are slightly lower in rural areas than in the urban areas, they're rising steeply in rural areas too. So obesity and overweight are becoming very common everywhere around the world. And this really matters because obesity drives the risk of many common diseases. And this figure just points out a few of those diseases. And it includes dementia and poor mental health, fatty liver disease, at least 13 types of cancer, cardiovascular disease, and all the different conditions that make up that collection of diseases, and also type 2 diabetes. In the rest of my presentation, I'm going to focus on cardiovascular disease and type 2 diabetes. So first of all, cardiovascular disease. And this is a very common condition. More than 400 million people around the world are living with cardiovascular disease, with all the problems for morbidity and for costs for the health services that brings. And the morbidity burden is unequally distributed. This map shows you the mortality as age-standardized DALYs per 100,000. The more blue the colors are, is the lower rates of mortality, and the more brown, the higher rates of mortality. And what you'll see is that there's much more brown in many of the low and middle income countries around the globe. So in many countries in Africa, in the Middle East, in Eastern Europe, and in Asia. And in this plot, we see the different conditions that make up cardiovascular diseases in the individual colors, and then the plot with the histograms shows you the age-standardized mortality according to where you are on the globe. So the highest morbidity burden for cardiovascular disease is in Central Asia, but Eastern Europe, and I put a blue arrow by Eastern Europe because this conference was taking place in Georgia, you can see it's the 3rd highest rates around the globe. And we know a lot about the risk factors which contribute to that burden of cardiovascular disease. They include environmental risks, metabolic risks, and behavioral risks. So if we look to begin with on the right-hand side at behavioral risks, you will see that the biggest behavioral risk is diet. So poor diet is a major driver of cardiovascular disease. And poor diet contributes to many of the metabolic risks. You see those in the middle. It contributes to high blood pressure, to high LDL cholesterol, of course to high BMI, to raised plasma glucose, and to kidney dysfunction. So diet really matters to cardiovascular disease risk. Now turning to diabetes, this is also a major cause of morbidity and mortality globally. And more than 500 million, that is more than 500 million people worldwide are living with diabetes. And most of those people have type 2 diabetes. Strikingly, 3 in every 4 adults with diabetes live in low and middle income countries. So this is not a condition of rich people in affluent countries. This is equally a disease of poorer people in low and middle income countries. And it's a major contributor to mortality, with over 6.7 million deaths annually due to diabetes. And the problem is getting worse. This is a projection. First of all, it shows you the rise in prevalence of diabetes over the last 30 years, and the projection for the continuing rise up to 2050. So by 2050, we expect the number of people living with diabetes to have reached almost 1.3 billion. And when you think that the projected global population in 2050 is going to be around 9 billion, a lot of those people are going to be living with type 2 diabetes. At the bottom of the slide, you show the data for type 1 diabetes, and you can see, by comparison, very little change in type 1 diabetes risk. So the big problem is with type 2 diabetes. And high BMI, that is being overweight and obese, drives the risk of diabetes, as it does cardiovascular disease, in many parts of the globe. I'm showing you here very recent data from China, where they had estimated the contribution by the change in BMI over the last 20 years or so to the increasing burden of diabetes and cardiovascular disease. And they estimated in that study that 17% of the mortality from diabetes and cardiovascular disease was due to higher BMI. The problem is similar in India, and I'm now showing you, like the previous maps, the distribution of prevalence of diabetes across India. The big map on the left shows you for all adults, and on the right for urban and rural areas separately. And you see that in urban areas, in almost everywhere in India, 10% or more of the population have diabetes. And even among the rural populations who tend to be poorer, there are many states where at least 10% of the population are now living with type 2 diabetes. If you look at dyslipidemia, here measured as low HDL cholesterol, the plot is similar, but indeed even worse than it is for type 2 diabetes, with the red showing that more than 60% of the adults in those areas in India are living with low HDL cholesterol. And this translates into very large numbers. The data above each of the bars in the histogram are millions of people in India. So you can see that about 350 million people in India are living with abdominal obesity, and more than 200 million with hypercholesterolemia, and more than 300 million with hypertension. So these obesity-related conditions are very common and are making major contributions to the burden of morbidity and mortality. Now, there are no quick fixes. These are complex problems, and they're not going to be solved easily. And just to give you one example of what we had thought might be a solution, that is to substitute sugar by non-sugar sweeteners. And earlier this year, the WHO, the World Health Organization, recommended that non-sugar sweeteners should not be used as a means of achieving weight control or of reducing the risk of non-communicable diseases, because evidence was accumulating of adverse effects when these non-sugar sweeteners were taken for a long time. So we need to improve the whole diet. It's not just about making small tweaks to the diet. And these are the recommendations from the American Heart Association for improving cardiovascular health. And the recommendations emphasize a plant-based diet with more fruits and vegetables, lots of whole grain foods, and healthy sources of protein. And at the same time, minimizing the less healthy foods, so beverages and foods with added sugars, because they contribute to the risk of overweight and obesity, and other foods like ultra-processed foods, processed meats, foods high in salt, alcoholic beverages, and so on. But it's not just about giving people good advice. We need to understand the circumstances in which people find themselves and how that contributes to their ability to make change. So this analysis, published very recently, looks at the way in which poverty within a very rich country, that is the USA, drives the risk of premature mortality. The brown line is for people in the USA living with poverty, and the blue line is for everyone else. And you can see that those with poverty die much sooner than those who are not in poverty. Importantly, in this analysis, that relationship was robust. In other words, it remained even when you adjusted for lots of other things, such as self-rated health, overweight or obesity, smoking, acute health events, chronic disease, and other confounders. So there's something about the individual's socioeconomic circumstances that contributes to their risk of poor health. And because we've seen this rise in poor health globally, a rise in obesity, a rise in many non-communicable diseases, there's been a lot of interest in the way in which other changes in the food environment may link to that poor health. And this recent article in Nature drew attention to the westernization of the Chinese diet and its links with adverse public health. And this is part of a growing interest in the wider determinants of health, so beyond what the individual can do, with a focus on the commercial determinants of health. So we've seen over the last few decades major changes in the way in which the food industry is organized and the way in which that contributes to what foods are available across the globe. Those changes have major impacts on the food environment of the individual, they influence the choice of food consumers, and they contribute to the health or poor health of the individual. And more recently, there's been a major analysis of the commercial determinants of health. This is part of a large initiative by the Lancet journal. And I'm just illustrating here one part of that analysis, showing the complexity of the factors which contribute to regulation, food availability, and so on, and which in the end influence what all of us do in terms of food purchase, food consumption, and long-term health. I'm here focusing in on one part of that, illustrating some of the ways in which a wide range of factors influence legislation and food availability, and particularly the important role of food marketing. And food marketing has also been on the agenda for the World Health Organization. And recently, the WHO has made a recommendation, a global recommendation, that all countries should implement policies to restrict the marketing of foods high in saturated fatty acids, trans fatty acids, free sugar, and or salt for children. And importantly, that such policies should be mandatory, and they're designed to protect children. And the WHO have worked with UNESCO to produce a toolkit to support the development and the implementation of mandatory comprehensive policies to restrict food marketing to children. So this is an important start in that process of addressing the balance between the power of the food environment to influence food choices and the ability of societies to protect the health of the consumer. But I think we can do better. And I think we must do better because there's overwhelming evidence that what we eat has such an important impact on our health. So there's a lot to do, and this conference in Georgia is part of that effort to improve nutrition and to improve health. So in this presentation, I've talked about diet as a major determinant of health around the world. There's a double burden of poor nutrition, and undernutrition remains a significant cause of poor physical, mental, and economic development. At the same time, and very often in the same places, and even within the same families, overnutrition, especially overweight and obesity, are driving a tsunami of non-communicable diseases, which is especially common and really difficult to deal with in low and middle income countries. And we need better, more effective interventions that recognize and address the commercial determinants of health if we're really to make a difference. Thank you very much.
Thank you, Professor. As always, we are very happy to hear this year from UK online. I think who attended last conference, you remember, Professor, visiting here, Georgia. Now there is only one presentation before the lunchtime. And this presentation is also about Georgian case study, nutritional education program for adults to address malnourishing among children. Please welcome Rosudan Huamichava, Associated Registered Nutritionist, University of Westminster.
many minutes?
Probably 5 or 10, 5 to 10.
We're really sorry, but we have got problem with the computer, so we'll resume it in 5-10 minutes. Sorry about that.
Sorry, can we continue? Yeah? I'm very sorry, we had some technical issues. And I will try my best to be super quick. I know you are waiting for your lunch. Dear guests, colleagues, ladies and gentlemen, I'm delighted to welcome you all on today's conference. Thank you for participation, for your valuable contribution and special opportunity to share the experience and this chance to learn from each other. I'm proud to be co-founder of Georgian Nutrition Society, and I would like to thank once again for our main partner, Nutrition Society of the UK, and of course for this year especially our neighbors, Sabina Ulker Foundation. From my side, I would like today to present some findings of the scale-up project of my PhD work, Nutritional Education Program for Adults Addressing Malnourishment Among Children, Georgian Case Study. During today's presentation, I would like to follow the following order. I would talk a little bit about introduction, problem, situation in Georgia, then I will tell you about hypothesis of the research, aim and objectives, of course then research methods, intervention process, and at the end results, analysis, conclusion, recommendations, and if you will have any question, we will have lunch time or later time for that. Developing healthy habits and behaviors starts in early years. The healthy lifestyle affects cognitive and, of course, physical development of the children, which can highly influence the outcome of adults' health. Healthy lifestyle in childhood is foundation for a lifelong health, rapid growth and development, and of course, the main thing, reducing chronic diseases later in life for long-term socio-economic impact. Raising nutritional awareness, especially among parents and especially among mothers, could potentially decrease the prevalence of non-communicable disease, such as dental caries, diabetes, obesity, and I will talk about it later as well. What is our problem? We talked a lot about obesity, cardiovascular disease, diabetes, but I would like to pay attention on malnutrition. Insufficient and imbalanced nutrition is related to health issues and especially the malnutrition, which is the universal problem holding back human development. Malnutrition in all forms includes undernutrition, wasting, stunting, and undernutrition, inadequate micronutrient intake like vitamins and minerals, and of course, overweight and obesity resulting also in diet-related non-communicable disease. Malnourishment in children has been linked to poor mental development, school achievement and performance, of course, and behavioral problem, making them more predisposed to chronic disease and illnesses later in life. And unfortunately, around 45% of deaths among children under 5 of age are linked to undernutrition. So malnutrition, the term malnutrition addresses 3 main groups and conditions. First, as you can see on the slide, is undernutrition, wasting like low weight for height, stunting low height for age, and underweight, low weight for age. The second group is micronutrient-related malnutrition, micronutrient deficiencies like lack of, for example, iron, calcium, especially in children, vitamins and minerals, and also it could be excess intake of it. And the third group is overweight, obesity, and diet-related non-communicable disease, such as heart disease, stroke, cardiovascular disease, diabetes, and some kind of cancers as well. So you might would like to know what kind of situation we have in Georgia. Unfortunately, currently there is no food and nutrition guideline for parents and children together in Georgia. And according to study in 2018 implemented in Georgia, school children experience malnutrition problems with 35% at grade 4 feeling hungry at school. This situation would impact, of course, pupils' academic achievement and performance, and the occurrence of overweight and obesity in Georgia is quite high among 7-year-old children, 22% among girls and 26% among boys. It had to be noted that in case of Georgia, the coexistence of obesity and undernutrition at the same time in the same population is a very typical case of double burden of disease. So, for the first time, we investigated nutritional knowledge of parents of school children and explored the most consumed meals at home. This helped us to develop proper nutritional intervention program. A hypothesis of our study was that family-based intervention promoting healthy eating among parents can increase the nutritional awareness with respect to children's dietary requirements, enhance their habits, and improve anthropometric measurements like BMI for age. This is the very first study in Georgia focusing on family-based approach to support and promote healthy eating and lifestyle. And this all was achieved by nutritional education intervention for parents. Our aim, the proposed study aimed to assess the efficacy of family-based nutrition intervention to address malnourishment and malnutrition in children in Georgia. And we had the 4 main objectives for the study. First one was implementation of the baseline survey for parents of the school-age children with purpose to assess their nutritional knowledge and understand children's diet. Second one was to develop special educational materials in Georgian language, which is a very important aspect. And third one was development of the recommendations to substitute the most popular energy-dense, not very healthy meals with healthier options with nutrient-dense ingredients. And the last one was to raise the awareness of parents about healthy eating and behavior with relevant, practical, everyday examples and recommendations. For our methodology, our targeted group, the participants of the study were parents of the public and private school children aged from 6 to 12 years old based in Tbilisi who do not receive any kind of nutritional education or classes at school. Participation was, of course, voluntary and fully anonymous. It's moving, yeah. And schools for this research were selected randomly. For these studies especially, we developed 2 different questionnaires for parents to identify their nutritional knowledge, diet, and most popular meals consumed in the families. The study included 2 questionnaires, Food Frequency Questionnaire, FFQ, as you can see on the slide, and KAP, Knowledge, Attitude, and Practice Questionnaire. FFQ questionnaire included questions about different kind of food groups and the amount of food, portion sizes, and this FFQ was already validated questionnaire created by National Institute of Health, and it was modified especially for Georgian parents and population, including some Georgian dishes and food as well. The KAP questionnaire was part of the FAO guideline for assessing nutritional related knowledge, attitude, and practices, and it covers questions about risk of deficiencies, physical activity, obesity, and different kind of important aspects. These two questionnaires together provided sufficient information to see the full picture of parents' awareness regarding nutrition and their children's diet. Of course, due to COVID pandemic, because this research, pilot phase of this research started during COVID, it was decided to conduct the survey online, and the ethical clearances was gained from UK and Georgia as well. Let's talk about educational materials. As I mentioned, one of our objectives was to create special materials in Georgian language for Georgian parents. The educational materials were created during preparation phase to educate parents about importance of nutrition in early ages. The nutrition educational curriculum was an intervention tool including 10 weeks program with 10 webinars, 10 important topics, and 10 meetings, including some presentation with visual materials and also voiceover explanations presenting the crucial key aspects for the children's diet and lifestyle. Participants for the scale-up stage of the study, the total participants at the beginning was 365 participants, parents, were recruited. Parents of girls were 186, and for boys 179. The 89% of them have completed the intervention, and final number was 328. The number of participants at the end was very impressive, and it was representing the results of Tbilisi. Intervention process included 3 main phases. First one was pre-intervention assessment. The questionnaire was delivered to the participant. They were given 1 month period of time to complete these 2 questionnaires, KAP and FFQ questionnaires. Then we had 10-week intervention program with educational webinars and e-meetings, which was on weekly basis. And the last one was, and the most important one, I would like to say, post-intervention assessment, because after completing 10-week educational assessment, the participants received the questionnaires for the second time, and it was very important to see both results to make a comparison of the results before and after educational intervention. Results represent the outcome of the conducted research based on these 2 questionnaires, FFQ and KAP. The BMI of the children of participants has been monitored before and after the intervention, and as it's described on the slide, and you can see, the BMI for age decreased. The proportion of severe thinness, and normal BMI has increased, but at the same time it's affected other categories as well. And the cases of overweight and obesity decreased in girls and boys altogether. For anthropometric measurements, WHO chart BMI for age was used, as you can see on the next slide. The stage of BMI for age is illustrated separately according to WHO recommendation. The figure 1 is about girls and figure 1 is about boys. And after intervention, we can see that distribution transformed and affected both genders. Based on obtained results related to habits, we saw a very important topic, which was breakfasts, eating breakfast on a regular basis. And according to statistical tests, the difference was significant, and the number of parents who reported that their children were having breakfast on a daily basis increased by 8.3%, which is a very impressive result just for 10 weeks of educational intervention. In a statistical analysis using food frequency questionnaire, FFQ, total energy and its sources were calculated. The ratio between macronutrients, carbs, proteins, and fats are a little bit different to compare, as you can see, before and after intervention. However, the results and changes are not significant, but however, there is a trend of protein proportion slightly improved by 0.5%, and we can see the reduction of carbs as well by 0.5%. The proportion of fats remains same, and it was 18.5%. And the last findings also I would like to share. The statistical analysis also included the comparison of children's diet in the families with different level of income. Figure on the slide shows that a portion of daily vegetable intake is bigger in higher income families, and it shows that in all type of income groups except lowest one, which is like monthly income less than 500 lari. But the other differences are significant before and after intervention. The education of the parents, especially mothers, via family-based nutrition education intervention could be a very first but big step to promote modification of the eating habits of their children, especially during childhood. Scale-up intervention underlined the importance of parental role modeling for the development of healthy habits and behaviors. The intervention had significant impact on knowledge, attitude, and practice of the parents, and which later can affect and influence children's physical and cognitive development. The findings of the study suggest that educational webinars proved to be highly impactful for investigating changes in relation of the habits and behaviors. However, the absence of personalized and individualized recommendation for individuals is determined as a notable limitation. As a conclusion, I would like to share that after attending the nutrition educational webinars, parents tend to make healthier food choices for their children, and increased nutritional awareness is very positively correlated to improved health habits and attitude towards suggesting nutrient-dense food options for children, for example, breakfast, as I mentioned earlier. To achieve a substantial improvement and ensure lasting changes related to habits, it is essential to execute more extended educational intervention than just 10 weeks of educational curriculum, and it was even advisable to incorporate the nutrition education into schools curriculum for early ages for children or for parents as special sessions. About recommendation, I would like to mention that it's worth highlighting that our study was the first important and very welcomed initiative by parents to respond to the problem of parents' nutritional gap in Georgia. All activities with the framework of the research had one main objective: to support sustainable long-term improvements of children's health in Georgia. This topic needs more attention, of course, in research studies, as family-based intervention could provide significant support to sustain long-term optimal growth and optimal health strategy for children and families at home. Thank you for your attention, and I'm happy to answer your question during lunchtime as well.
Okay, thank you to all presenters of the first part of this conference. I think now it's lunch time, and we have 1 hour for our lunch. Enjoy. It will be upstairs at the same place where you have a coffee break.
Hi, Oliver, can you hear me?
Yes, I can hear you.
Okay, wonderful. Can we please check your presentation if it's all right?
Yeah, of course, yeah. I'll turn
Great.
my camera on as well. So you
Okay,
can
great, thank you. Yep.
okay, yeah. Is that showing anything?
Not yet, but I will double check with tech team. Give me a second, please.
Okay.
Yeah, everything's fine, Oliver. Thank you so much. We'll start in a few minutes and we'll let you know. Thank you.
Okay, amazing. I'll stop
Yeah.
sharing.
Okay, I think everyone can hear me better now. So, welcome back. We're back with our conference, and our next speaker will join us virtually from the United Kingdom. We are welcoming Oliver Shannon with presentation about Mediterranean diet and risk of dementia. He is representing Human Nutrition and Exercise Research Centre, Faculty of Medical Sciences, Newcastle University, UK. If you can hear me, Oliver, we are ready for you.
Hi, yeah, thank you very much for the introduction.
Thank you.
I'll just share my slides. Can you see that?
Yeah,
okay?
we can see it. Yeah, perfect. Thank you.
Okay. then used to help if the project sample size required for. Which is a European debt set that in non-Mediterranean countries that were generally studies are reporting beneficial associations between Mediterranean diet adherence and cognitive health in the Mediterranean region than have done so in non-Mediterranean studies. So why might the Mediterranean diet be more effective in Mediterranean? Consumption of fish, legumes and olive oils, which might be less frequently adopted in non-Mediterranean countries. In non-Mediterranean countries, whilst individuals might adopt some principles of the Mediterranean diet, it's very likely that individuals still maintain some consumption of classic kind of Western foods, and there's some evidence from studies published in the past couple of years to show that co-consumption of Mediterranean and non-Mediterranean foods might diminish some of the effects that we see compared with just consuming those Mediterranean foods on their own. Equally, it's possible that the Mediterranean diet adherence laws might be capturing other lifestyle factors for studies carried out in the Mediterranean region, like sociability, conviviality, and high physical activity. And finally, if we look at observational studies, it's possible that individuals who show high adherence to the Mediterranean diet in non-Mediterranean countries might have more recently changed their diet towards this way of eating. So it could be that they've followed the Mediterranean diet for a shorter period of time, which we might expect to is the mind diet, which many people have heard of, which is a sort of a hybrid between the Mediterranean diet and the DASH diet, or the dietary approach to stop hypertension. It's very similar to the Mediterranean diet, but has a few key differences. So, for example, the mind diet specifically emphasizes consumption of berries and also emphasizes consumption of green leafy vegetables, both of which seem to have particularly strong links with cognitive outcomes. And there's a number of observational studies now showing that following the mind diet might be particularly associated with strong protective effects or benefits against dementia risk. Nevertheless, many of us were quite disappointed to see findings from a very large-scale study of the mind diet, which were published earlier this year, which unfortunately showed no benefits on 3-year intervention with a mind diet on cognitive function. So this was a mind diet which was provided alongside mild calorie restriction versus just the calorie restriction alone. And the study, lead author of whom was Barnes, this is a study carried out by the Rush group in America, really showed no benefits on cognition or MRI outcomes or brain imaging outcomes over the 3-year period. So really more research to be done to understand whether actually intervention with a mind diet can help improve cognitive function. So I'll wrap up my presentation now, just to note that the Mediterranean diet is one particularly promising strategy which seems to be linked with better cognitive function and reduced dementia risk. I've just presented a subset of research on this area today. So these are studies which we've carried out in our group, but just to note there are a whole host of other studies which have verified and substantiated these findings in different settings and cohorts as well. We do see similar beneficial associations for other dietary patterns like the mind diet as well. But at present we don't have a huge understanding of what the mechanisms of action are to drive these beneficial effects. But some hints in the literature suggest that there may be both direct benefits of the Mediterranean diet and brain health, which could be related well, such as modifications to gut microbiome, which could potentially benefit the brain by, for example, production of short-chain fatty acids, improved cardiovascular health, such as reduced blood pressure and improved endothelial function, and also decreased inflammation and oxidative stress, all of which collectively could help with brain health. But there's still considerable scope for more research in this area. In particular, we need more long-term intervention studies focused on hard clinical endpoints, looking at whether intervention with a Mediterranean diet, either alone or alongside other co-interventions like physical activity, can lead to better cognitive function and reduce dementia risk over time. We need more mechanistic studies to understand how these effects might be occurring. And we also need to understand factors on an individual or group level which might account for response heterogeneity or differences in response between individuals, such that we might be able to better target this dietary intervention towards individuals who are most likely to benefit from it. One final point which I think is particularly needed is that whilst I think it's very important to keep building the body of evidence around the Mediterranean diet, we also need to be aware of cultural dietary practices and dietary approaches which are already advocated in countries. And we need to start building more deep evidence to show whether the dietary recommendations of individual countries and the diet that people currently are more likely to consume are also beneficial for cognitive health. For example, in the UK, we have the EBOG guide, which is used as a model for healthy eating. And at present, there's very little evidence to say whether following the EBOG guide is actually linked with better cognitive outcomes. So, more research needed to understand whether these diets, which are recommended in policy and in clinical practice, which reflect national dietary guidelines, are also beneficial for cognitive health. And then my final slide here, just to say a huge thank you to all of the many researchers who've been involved in the work that I presented here today, and particularly the Medics UK study team, which is led by Professor Anne-Marie Linehan, and my colleague Professor John Alice in Newcastle and Professor Sarah Aldred at the University of Birmingham, and the New Brain team, which funded some of the prospective cohort study work, which is led by Professor N. Stevenson. And finally, I'd just like to finish my presentation with a picture of my dog, who sat on my lap whilst I was carrying out many of the cohort study analyses, kept me warm through many cold nights. So final tip of the hat to her there. So thank you all for listening, and at this time I'd be delighted to take any questions.
Thank you so much, Oliver. It was an amazing presentation, and I think I won't be wrong if I say that the last slide was one of the most popular ones because of the dog. So thank you for sharing. I don't think we take any questions at this point of the conference. I believe we're going to have some time dedicated to it in the end of the conference. So if there's anything, we will send it to you through emails if it's all right with you.
Thank you very much. Thank you very much for having me.
Thank you for your time, and sorry for keeping you waiting. So the next presenter. Okay, yeah, it's much better now. The next presenter is Professor Nurbaran Aksakal, who will present about nutrition education for family physicians, an example from Turkey. We're very excited about this presentation and looking forward to your speech. Please.
Check, check, check, check, check. Check, check, check.
You had a very good meal. The meal are amazing here, and all the food that we had until we got here was amazing. So thank you for that. And I'm still, in fact, I'm really curious how you could be one of the least overweight populations in Europe, didn't you, Julia? With this kind of food. Congrats for that. Now, I will be talking about the nutrition education for family physicians. Let's move to the other side of the, I don't like to use this one, in fact. It's only for singing and dancing, so presentation is hard with that. Okay, now, this is the other side of the story. Because, yes, we are trying to prevent health, and we are trying to live a healthy life through prevention with a healthy diet. I think this is also not working well. Is it okay? Okay, so the other side, when you get ill, what happens? Now you're diseased with a diet, or you have a disease that should be cured by a physician, and physician is one of you. And under the influence of the infodemia, what you read, infodemic every day, disinformation, malinformation, misinformation everywhere, and lots of kinds of nutrients that is promoted each and every day. Some of them are out of fashion, and the others come into scene. So what will happen when you see a patient which has a real problem, which has a disease that is very much related with diet? Have talked about the double burden, which I believe that is very important, which means that there is also malnutrition, vitamin deficiencies, anemia, and also long-term issues like bone health. So with keeping this in mind, another presenter also said that are we what we eat? Yes, and each and every day different nutrients are being blamed, being responsible for causes of some diseases, while others are rescuers. So what's the evidence behind that? So this nutrition and health is very much interrelated. And since all the presenters have said till now, starting from Julian and Diana and the others, it has a very strict relation with being healthy and be healthy in the future that you will live. Now, in the acute care model, that is usually when we meet our physicians for the first time or a chronic disease, patient comes, gets the treatment, and leaves. But chronic diseases are not curable, and you can't do it only with rapid care. It needs follow-up, but it needs a very important group of lifestyle changes, which includes diet. If you don't keep them, then you will be diseased and you will have complications for sure. But when you see a knee with a problem, he has difficulty in walking because there is an arthritis, and you say to them, lose weight, but it's not easy. It's just an ordinary recommendation that's given. Or if he has a diabetes, the physician says, yes, I'm prescribing you insulin and the other anti-diabetic drugs, but you also need to use this, and you have to avoid that, and that's it. So there's a problem with an acute care problem. You have to work for getting rid of the risk factors instead. And there's not that much time for the physician, and there's not that much training background of each and every physician having a nutrition communication, and they're not, in fact, weighted to be so. And so there are determinants of health, which are social, economical, environmental factors, but on top of that, we have health behaviors and risk factors, and diet is very much related with your culture, with your background, even with your political view that where you're living. And what can we do? We're trying to prevent. if we can't prevent, we're trying to make an early diagnosis, if possible, and then we have to transit to the good management in order not to have the complications. So the burden of disease can only be addressed, be reduced by addressing the root causes of the diseases. So what does WHO say? As many others said, we have underlying socio-economical, cultural determinants like globalization, urbanization, etc., but we have limited things to do on that. What we have, common modifiable risk factors, which unhealthy diet is one of them, and physical activity is the other, and very much linked to each other, the brother of unhealthy diet. And then what happens, there's an intermediate risk factor, which is an endpoint of the unhealthy diet, which is overweight and obesity. And we know that, as Diana said, 41% of all the chronic diseases is very much related to the nutrition, and 61 of them being the cardiovascular diseases, followed by diabetes. So what we can do, we cannot just cure the patient and send home. So we have to be aware of the risk factors. But it's not the solely responsibility of the patient or the physician, as some other nutritionists and dietitians, in fact. This is a responsibility that should be shared from top to bottom. Now, background facts. There's no formal education training for medical professionals, and we're not trained. I'm a medical professional. I'm Dr. Nurbaran Aksakal, and I'm a medical doctor, and I'm a public health specialist, and I had no training on dietitian or nutrition, nothing, no formal education. What I know is if somebody is diabetic, she should be aware of which diet increases the glucose level. Then if I'm skilled enough and if I am specialized enough, I'm sending it to him or her to a dietitian or a nutrition. That's it. And there's scarce dietary nutritional recommendations which can be translated to everyday life. This is very important, I think, because we may give some advices, but they need to be evidence-based, but which is also applicable to the everyday life. And weak collaboration between medical professionals, dietitians, and nutritionists. I think this is the worst area in my country, in my homeland, Turkey. Because we just send them if we have someone we know, and if it is a very specific kind of disease like diabetes, we have dietitians that are really helpful or can work in collaboration with the medical professionals. And lack of information and knowledge on how diet contribute to management of non-communicable diseases, chronic diseases. Yes, we are well aware, but it's not easy to show it because it's a long lifetime period. And as Hanan has showed us, it's not easy to just document the link or how you eat or how you live with a non-communicable disease because it's multifactorial. So there's a problem with the lack of awareness. And so what do we need at this stage is nutrition communication, but nutrition communication not only with the patients or the public. We also have a nutrition communication within the professionals, medical professionals, and physicians, dietitians, nutritionists, etc. So what is it? They are the techniques to inform, influence, and motivate individuals, institutions, and community groups on important nutrition issues, which I will talk about in a minute. Sabri Ülker Foundation, which I believe I'm proud and really happy to be in the family, because the aim of the foundation is just within this scope, I think, which is very important. So you need multi-partners, you need advocacy, and you need science, and you also need finance to do all these. So this Sabri Ülker Foundation, as described before, it was established in 2009. I don't want to repeat myself, but you see these are the science committee members. Everything is tried to be done on the scientific basis. And this is one of the clues about that, I believe. And we have members here, İrfan Hocam, and Zeki Hocam was here, you're here, and Julian, of course, Diana here. So we are a great team, I think, all together trying to work to increase the awareness. So as Julian has said too, it has three pillars, operational pillars: education, research, and communication. And there are lots of projects going on. I wanted to use this opportunity to make you know the foundation better, because really they are contributing here, but they have a great potential to contribute in the future for your future work, and having Julian and all the other team members on board. So the program, there are lots of programs, and there are also scientific background, scientific media that you can use, and they are trying to increase the health literacy among the journalists and the social media influencers, etc. And they have also nutrition education for medical students and medical professionals. In fact, they are not giving the education, but they are providing a ground for discussion and scientific meetings. And this is also very, very valuable. And also there are publications for the public, there are health summits carried out, and there are conferences on nutrition during, for example, the pandemic, and other training programs and the conferences they are hosting. Also, there is a metabolism laboratory in Harvard, having Gökhan Hoca, Otamışlı Gil, and there are also awards given each and every year. So this is a great opportunity for me to thank you as a team. Really, this is a hard work. And here now, I am able to present what we had done under this umbrella. Now, we have, this is, what we tried to do here is we just wanted to increase the awareness, in fact, and a certain level, the knowledge of the medical physicians. In fact, they are family physicians, which they face individuals or patients each and every day, and have limited chance to work with the dietitians or nutritionists in collaboration, because they are their own and they are facing each and every day many patients with many diseases. So they need to increase their awareness. It is needed, in fact, along with the knowledge, because you know, we didn't have any formal education, as I have mentioned, and community health or nutrition is not one of the top areas they are interested in. So we have started with this, in fact, collaboration. This is the Federation of Family Physicians Associations, the other partner during our training efforts. We have 81 provinces in Turkey. We are 83 million populated country with a large one. And we have 81 provinces. And this is each and every province, almost all of them, has a association of family physicians of their own province. But this is a federation which unites 76 of them. So this is one of the biggest associations in Turkey. And it had the members of the 74 associations were our study population. So what we tried is we gathered the stakeholders together. Sabri Ülker Vakfı, along with the Federation of Family Physicians and their online platform, AHEF Academy, which is a scientific platform for training and education purposes. We all use this media to have a training for the medical physicians. Now what we did, as most of the training programs, we started with identifying training needs assessment, and then we planned the online courses, and then we implemented the courses. And then of course we had a limited assessment. Now what we did, the aim of the study was to develop nutrition and nutrition communication trainings for physicians. We started with family physicians, but we will try to extend it to some specialists like pediatricians, internalists, and the others who are related or who have diseases very much related to the diet itself. And with this program, it's aimed to present the concept of adequate and balanced nutrition to physicians, the place and importance of nutrition in diseases based on evidence and scientifically, and acquire communication skills that may be necessary while transferring this information to their patients. So we started with a needs assessment, and we had a questionnaire. In this questionnaire, we had some socio-demographical data like age, years of experience, but also we had self-evaluation questions that are used for patients' nutrition-related questions, if they are recommending vitamins, etc. And their knowledge level about nutritional support and elements are also asked for an extent. Now, there are 26,000 family physicians that were during the time of the study, and 25,000 of them were our universe. But you know, it's not easy to take the family physicians for a training within the weekdays. So the online option was an option for us, so we used that option. And we sent 1,308 family physicians through the academy this questionnaire. And they replied to this. In fact, we sent it to more than 5,000, but this was in return. And almost half of them were women, and median working time was 15 years, as you may see here. There are also physicians that has experienced more than 15 or 16 years, but usually they are 0 to 15 years experience. Now, this is the training needs assessment questionnaire, and these are the questions that we asked. The first one is, do you feel competent while answering your patient's questions about nutrition? And you see, almost 1 in 5 said no. Even if they are assumed that they had to know everything, or at least the diet and recommending the diet to the patient. They strictly said no. And the others, you see here, almost more than half of them said partially. And only 1 out of 4 said yes. And this is also questionable. And do you recommend supplements, vitamins, mineral supplements to your patients? And you see, although they don't have any idea, some of them, they say no, still 77% is recommending. And do you find your level of knowledge about the usage areas of, areas of nutritional supplements, or is it sufficient for you? They said 1 out of 4 said no. And the others, partially, 63%, and only 13% said yes. So I in fact am familiar with the family physicians, and I am also one of the physicians. And it's not easy for us to say yes, but it's not also easy for us. It's maybe harder to say no. If they say no, this is an iceberg. This means that more of them would say no, in fact. And which one of the following subjects would you like to receive information? And they said, you say the leading one is weight control approaches, because overweight is a big problem, like elsewhere. So they want to be active on weight control approaches. They wish they would know more on that. And the second one is the relationship between supplements and disease. Why? Because they hear, they read, although they didn't have the formal training, they are exposed to the same infodemic everywhere, plus the patients are asking, I'm using this one, and you're prescribing this drug, should I go on with that or not? So this is what they need to know. And thirdly, as well as I see, the vitamin supplements, and then the nutritional fortified foods, mineral supplements, other supplements, probiotics, you see. 1 out of 3 doctors almost said that they need to know about probiotics, which was so fashionable. And I think it's losing its popularity these days, but still, so. And here, 1 out of 5 physicians said nutrition communication, because they are trying to convince their patients about dietary issues, but nothing happens. The next time they come with more kilograms gained. And they feel themselves useless at the end, really, because you just prescribe, they go, they come back, you prescribe, you recommend, they go, they come back, and nothing improves. It's not easy for a physician. So training needs assessment questionnaire, their own statements, 23 said all of the above, all are important because they want to learn everything. The others, they do have detailed information about the interactions of vitamins, minerals, supplements, etc. Interaction with medicines, drugs, supplement use in athletes, healthy eating, healthy food preparation, nutrition in chronic diseases, weight control, nutrition, disease and diet, which vitamin, mineral groups should be given, for how long, what time should be cut, functional medicine, glutathione, pharmacokinetics, enteral nutrition, and one said, of course, these are useless. And the other one said, none of them. Nutrition is the job of nutritionists. It's not my job. You may or may not agree, but still there are physicians that think like that. And nutrition and disease relationship, I have more than one answer. I want to know all about probiotics, etc., etc. So these are the ones that we left a space and they wrote it. So this is what you see. The family physicians usually are lacking information on many areas, and they say and declare their needs to learn about all these topics because they are facing the patients and because the diet is very important in chronic disease management. And so, as I have told you before, we gathered together and we evaluated the needs assessment and we set the topics. And we selected the topics and we also selected the tutors, let's say, or presenters, because it's not easy, again, as I have mentioned, to gather the family physicians on their weekends and having face-to-face trainings. And I think it's also not needed in this age. So what we did is we prepared an online training in collaboration with the Sabri Ülker Foundation and Family Physicians Associations Federation and the Academy. So these are the sessions. It was 8 weeks session, and every 2 weeks, 8 sessions, one session every 2 weeks for 2 hours. In fact, we have decided for 1 hour or 1.5 because we were using their lunch breaks, but it turns out to be they need more discussion, so 2 hours, 2.5 hours are many discussions in some sessions were lost. So this is the first session, what's nutrition and what's not, because we wanted to start from scratch, or ABC. So this what's nutrition, because nutrition and diet, as in many platforms, is being discussed. So we should start with that. And then pre and probiotics, because it was one of the top topics that needed to be learned. And we had, I'm going to get my vitamins checked because this is one of the most frequent admissions to the family physicians these days. I want my vitamins checked. Why? Because my dietitian asked for. So why and how we will be collaborating on this. And vitamin and mineral supplements, to whom and when, and do you need to be fed or do you need a real nutrition? What's the difference? And nutrient-drug interactions. Sorry, this is my translation, but I hope Julian has better, phrases for that. But sorry, Julian, I'm not a native speaker. This is what I could do. Nutrient and drug interactions. This was really I think this is more than 2.5 hours, and they asked for new sessions on this topic. And where are dietary supplements in health protection and promotion? And starting with, again, what is dietary supplement, how you can use it, etc. And popular diets, of course, because there are individuals really trying popular diets and being negatively affected. And this is my way, healthy lifestyles. I have lectured this, and this is really very important because there are other components of healthy lifestyle, and we also discussed these as well. So what are the views here? You see 8,900 views, And of course, this was, I think, 6 months ago. It is improved. Why? Because we kept them at the Academy's website. So each and every family physician has the passcode and the link. So they are still watching it again and again, or sometimes when they find time, they will go to visit the website. So we have reached a huge group, I think, and the number of questions which is written and sent online was 192, which is one of the biggest number that I have seen in a scientific session. It's really, they are asking. They are really needing more information on that. So I just want to say this was our study. How, of course, assessment is very critical. We had an immediate assessment which was 98% very positive, and they have met the needs, etc., etc. And but I have to confess that the late evaluation was not, late assessment was not done properly, because in fact this was the first, let's say, pilot study that we have started in a very short time, and we wanted to see first what's going on, if they are really in need of it, if they're really interested in it. And now we're preparing it for specialists, as I have said, starting with the internalists. And I have to also acknowledge Professor Dr. Serhat Ünal here. He is from Hacettepe University, Internal Medicine, and we have started all these together, and now we will go on with him with the internalists as well. Now, nutrition communication is, I think, is very critical, and an area that you and me and all others should work on more, because conveying a scientific message does not mean that everyone understands and accepts it. You have to communicate. I am also involved in the vaccine communication. I personally have seen that the communication is a very wide area, widening each and every day, and is very much needed to transfer the basic messages that you want to give. Otherwise, they will not take it. And again, for this one, we need science, of course, but we need collaboration with the opinion leaders, health professionals, and of course the consumers. Otherwise, we will not be reach what we are looking for. So the last thing that I want to share is communication is not easy, because we are individuals and we have a battle has more than, I think, 4,000 years. Facts and beliefs are always in struggle with each other. We are promoting facts, we are bringing facts on the table, but they are coming us with their beliefs that have already formed before us. And these beliefs are now modified by the social media, modified by the disinformation, misinformation. These two are worse because it's intentional. It is aiming to harm individuals with these information. So this is a really big science, and what we have to do as a medical professional, each and every of us, we have to keep in mind that the fact that we're presenting, if it is consistent with belief, it's accepted. Because having round holes here depends on your political view, depends on where you live, depends on the food that you have already and your cultural choices, etc. So this is, if it is consistent with your belief, you take it. If conflicts with the belief, then it's rejected. So what we have to do as medical professionals is reshape it and just change the belief and make them accept it. Otherwise, it's not easy for us to communicate with the individuals. And this is called framing in communication. And it should be also done for dietitians, nutritionists, and nutrition societies, all the ones involved here. So what's the key? It's the adequate and balanced nutrition. So we have a long way to go, but I trust we will do it at the end, and we will promote what we're trying to do. Thank you very much.
amazing presentation. Thank you so much, Professor Aksakal. I cannot stress enough how relevant this work of yours is to Georgia, because we are facing the same issues and same challenges here. And it's amazing work, really impressive. Thank you. Now we have coffee break. I advise you to take 15 minutes, please, and then let's meet up again here. Thank you.
Check, check, check. 1, 2, 3. 1, 2, 3.
gather and continue. If you know someone who is out of the room, please call them. It's your presentation or Caroline's?
This is mine.
But it's yours time?
Yeah.
Yes, and then the Caroline will go.
Oh, I don't know actually, because I put it in there, so I think it's me now. Yeah. I know you did say, yeah, but they've got it set up.
Okay, thank you once again. After the last coffee break of this day, now it's time to go at the end of the second part of this symposium. And I will just remind that it's related to the nutrition and public health in general. And the next presentation is about an industry perspectives on achieving improvements in the nutritional status of society. Please welcome Dr. Caroline Saunders, Senior Director of Global Health and Wellness, Pladis Global.
Thank you. Say that again.
You should speak here and
Yes. Are you going to put
I hope I pronounced your name.
Yeah, you did. Thank you.
Yeah. Okay.
Yes, that's it.
Good luck.
Okay, thank you very much for the organisers to invite me to speak today. I'm absolutely privileged to arrive in your lovely country and be given this opportunity. So I'm going to talk to you today about how industry can help deliver great tasting, healthier products to their consumers. And I mentioned the word tasty quite a lot in my presentation, and that's because if we don't provide great tasting products, then our consumers won't buy them. So before I go into the main part of the presentation, I'd like to just give you a little bit of an insight into me. I see there's some young people here, probably starting out in their journey in the nutrition world. And I actually started my journey as a mature student. So I made the decision when my son was 5 years old to go back to studying. And I actually did a degree in nutrition and food science at the University of Reading, which you've heard mentioned today because Eka will be joining there later in the year. I stayed on and did a PhD, and then I started my journey in industry. And the reason I wanted to work in the food industry is because I thought I could make a difference to a bigger group of people, and it's been an incredible journey. So I'm going to touch briefly on what I did in my first two roles, but spend the rest of my presentation talking about my current role, which is working for a company called Pladis, who I will show you what they sell, and you'll all be familiar with some of the brands, I'm pretty sure. So I started the working in the food industry for PepsiCo, and I worked on their soft drinks, particularly their Tropicana, hence my interest in the fruit juices over at the back there. And my role there when I started was to look after a program, well, set up and manage a program of clinical studies looking at a new innovative product that they were planning to launch, which was an orange juice, so a normal, regular, not from concentrate orange juice that had the part of the waste stream added back into the juice to make it more like a whole orange. And we demonstrated that actually this fruit juice with the fibre had the same physiological effects as the whole orange, which is really interesting. I then went on to Suntory as a principal nutritionist, and Suntory own a company called Lucozade, Schweppes, Orangina, Ribena, a number of brands in Europe, as well as being massive in Japan. I was the nutritionist for the European business, and the first job I had to do was drive the sugar reduction program in the UK. And this was very timely because the sugar levy, which you heard about this morning, where basically if your product contained over 5 grams of sugar per 100 ml, you would have a big tax. So I actually managed to persuade them, with the help of the sugar levy, to reduce the sugar in their whole portfolio by 50%. So, which was huge. We took billions of, it was a lot of consumer complaints. It was quite a tough time, but anyway, that was a really exciting part. So then I decided to take a bit of a change and move into the snacks world. So I'm now working as Senior Director of Health and Wellness in a company called Pladis. Now, Pladis are the second biggest biscuit manufacturer globally, and they have 23 bakeries in 11 countries, and I'm still working my way around them. We are the 7th biggest chocolate manufacturer, and we have 16,000 employees worldwide. We are the 9th biggest savoury biscuit manufacturer, and we produce 7 billion packs of biscuits every single year. And we've also supported a lot of underprivileged areas during COVID, where we gave 13 million packets out to people in the COVID. Now you're probably thinking, well, she's telling me all of this, but I don't really know who Pladis are. I know some of you will know Pladis well, people from the Sabriolka Foundation, but this is our brand. So I think they sell them in Georgia, but I have not had the opportunity to go in any shops yet. But that will be my job definitely Thursday morning. So Ulka is very famous in Turkey, and I presume Georgia as well. And then the products that you see over the right side are based European and UK products. And it's massive in the UK. And the great thing about these brands is they're very much iconic brands that have been in the world for many, many years. I think a number of them are over 100 years old. So it's great to work with such sort of, iconic brands. But we know that the world is changing, and my role as a nutritionist, and I have one of my colleagues working with me today, Gemma, our job is really, one of our key roles is to advise and help the business make their products healthier. So I'm going to spend the rest of the presentation talking to you about this. And those of you that are coming to my workshop tomorrow, you'll have the opportunity to taste some of the products that I'm talking about today. Not from my company. I've bought a selection, actually. One of them is, but I didn't want to be biased. I want to talk about because these methods are quite general that I'm going to talk to you about now. Okay, so before I dive into this, I had a big job to do when I joined Pladis, and this was 18 months ago. We had individual businesses in Turkey, Middle East, India, Nigeria, UK and Europe, and they'd done some great work reducing sugar, reducing fat, reducing sodium, but we didn't have a universal way of measuring the health of the products. So it was so difficult to be able to, well, it was impossible to say Pladis have done this, Pladis have done that. We couldn't compare them. So my job was to develop a global method of measuring health based on science. And actually it turned out to be quite a bit easier than I thought, because actually when I started looking at the methods that were currently being used in the world in which we operate, the Pladis world, there are 3. One is the health star rating, which you'll see here. I better not go too far away from here because you won't hear me, but 3.5 stars and above means a healthy product. In the UK, we have the nutrient profiling model, which determines whether a product is high in sugar, fat or sodium or not, okay? And that's a yes or no, is it healthy or isn't it? And then you're probably familiar with the Nutri-Score, which is a pretty controversial method, purely because it's quite political in Europe. Many countries want to use it, others don't. But when I started looking at the algorithm behind these three methods, they were actually really similar. So they're based on a balance of nutrients to encourage and nutrients to limit, which I'll remind you of in a minute. And you get points for each component. One is subtracted from the other, and you get a score. So 2 or less is great for the health star rating, 3 or less for the nutrient profiling model, and 2 or less for Nutri-Score. And I thought, well, if I'm showcasing this to marketing people and sales people, it's a bit strange that the lower the score, the healthier the product. So I came across an equation that Mike Rayner, who you may know of, he's a well-established academic, he developed this simple equation to change the nutrient profiling model score to a positive score. And I've just put it down there, but it's very simple. So what we decided is that we would use the UK nutrient profiling model to measure the health of our products globally, but in this version, so the higher the score, the better. But we would adjust the boundaries conservatively. So we wanted to make sure, because Nutri-Score is a little bit tougher than the others, so we wanted to make sure that if a product developer was developing a product in the UK that was healthy, it would still be an A or a B in the Nutri-Score. So we did it, we rolled it out to the whole of the business, and trained them, the R&D and the marketing, on how to work out these scores, and we provided a calculator for them, and now we have a global method of scoring our products, which is really great. Now, I mentioned before about the scoring being based on a balance of the nutrients to encourage and the nutrients to limit. And just a reminder of those, I'm sure all of you who are nutritionists will know this, but the nutrients to limit are energy, saturated fat, not total fat, this is important here, sugars and sodium and salt. And then the nutrients to encourage are fruits, vegetables, legumes, nuts, fibre and protein. However, Nutri-Score in Europe have changed their model, and nuts are no longer a nutrient to encourage. I do not know why. If anyone can enlighten me after in the break, it would be great, because we don't know. But we've had to adjust our calculator and everything because of this one. So, knowing what health means, okay, because it's important we have a scientifically validated method of measuring the health of our products, I'm going to talk you through 3 approaches of how to improve the health, okay? So increase the scores, basically. So one is reducing the nutrients to limit. Now, there are 3 ways we can do that. One is silent reformulation, and this is where we gradually take out the sugar, the sodium, or the fat, okay? And generally, you can take out about 10% of the sugar and 10% of the salt before consumers can taste a difference. We would recommend doing it in 5%, then another 5%. Otherwise, consumers reject it, and they'll buy the competitor. So, and we have done that in the UK on our 10 top biscuits. Just silently reduce this. Another way of making the products healthier, which is a way I'm quite passionate, is to reduce the saturated fat content. So you've probably all heard of palm oil. Now that's around 50% saturated fat. If we move to an oil such as, they call it HOSO, it's high oleic sunflower oil, we can take the saturated fat down by around 50%, because the saturated fat content of Hozo is only 5%. Now, this is not possible in all products. It's really challenging. Biscuits break, but what we found is we can use it very well in spray oils, and we produce some savoury biscuits that have a spray oil, so we can certainly use it in those, and in certain savoury biscuit it works really well. So that's one way of doing it quite successfully. Secondly, portion control, and this is a big thing that Gemma and I are pushing. There will be products that we come across that we sell that are indulgent, and they will remain indulgent, because if you take sugar and fat out of chocolate, it no longer becomes chocolate anymore. You know, so there is only so far you can make sugar-free chocolate, but so what we have recommended is that we should really provide portion control products for our consumers. And we've got a big project in the UK at the moment going for less than 100 calories across for all of a lot of our products, and that includes single serve and also multi-pack. So if you buy the 6-pack of crisps, we must make sure that there are single packs inside that have 100 calories. Now, Turkey, and that we'll probably find them in Georgia, they have some great examples of this. They do really small little chocolate treat bars, you know, under 100 calories, which is absolutely perfect. They do it in India. This is our company. I came across mini packs of biscuits that are 5 cents, that again, less than 100 calories. So that's a very effective way of dealing with your treat products. Finally, on this part, the reducing the nutrients to limit, nutrient reduction at greater than 30%. So we can do the silent reduction, but it's a limit. You know, if you think of a biscuit, you can't there's only so much you can take out before it's nothing. So one effective way that we have found is, and it's not just unique to Pladis, I'd like to think it was, but it's not. There are certain fibres that you can use to replace sugar. Soluble corn fibre is a really nice example because it's a plant-based fibre, and you can remove a certain amount of sugar. We've done it up to 30%, and you've therefore got 30% less sugar and around, say, 20% less calories when you take in the difference between the calories for fibre and the sugar. I mentioned the saturated fat reduction using the healthier oils. Again, you can do that very well. And those of you that are coming to my workshop tomorrow, I will showcase how one of the biggest food and drink companies in the world have managed to reduce salt by a significant amount, because you'll get the opportunity to taste those. But if I'm brutally honest, there is only so far we can go at the moment. So what we are doing at Pladis is collaborating with universities, experts that can help us on our journey. And one of those is a university called Wageningen. Very difficult to say this name, but we have joined a collaboration with them, and they're looking at artificial intelligence to help the food industry with lowering calories. So that it's really technical. They're looking at how we can replace calories with fibres and other ingredients to give the same sensory properties as the original counterpart. So no sort of problems with texture, taste, or anything. And that's just been kicked off. So that's really exciting. So we hope we collaborate. We pay a small amount into the funds of the resource, but we also offer our expertise in kind, and we use our baking capabilities to produce products for them. So it's a win-win really, and hopefully from this we'll get some really interesting data that can help us. So the second method, which I think is probably one of the most exciting, is increasing the nutrients to encourage in the product. So we've talked about taking out the baddies. This is about thinking about snacks very differently and how we can make them healthier. So we can replace nutrients to limit with nutrients to encourage, which I've talked about just now. So we can use sugar and fat replacement with fibres. But one of the very interesting things I think companies like ours that produce a lot of baked goods can do is thinking about healthier and more sustainable versions of wheat. So using different flours. And I'm going to put these two both together here, the indigenous grains and the pulse flours, because they're very similar. So the ancient grains and pulse flours, they are often, definitely with the pulses and mostly with the ancient grains, they're more sustainable. So with the ancient grains, they seem to thrive with lower levels of pesticides, fertilizers and irrigation, so you can grow them in a drought conditions. And we've actually recently launched, which I'm really proud of, in Nigeria we've replaced 15% of the wheat flour with sorghum flour in our biggest sellers in Nigeria. And we're hoping to push that up to 25%. So the sorghum is health, it's higher in fibre and protein, it's indigenous, and it's more sustainable. So it's a really nice story there. And I hope I'm allowed to say this, but we have got a new product for India, which is a millet flour-based product. And again, an indigenous flour with some great health credentials. Millet is so popular in India. Everywhere you go, you'll see the story of millet and unrefined grains. So that's the story with that one. Pulse flours, you probably think, oh my goodness, what would something taste like if we put something like chickpea flour or lentil flour in a product? But Gemma can support me here. We've made some really nice products by taking out quite a high proportion of the wheat flour and adding pulse flours. And pulse flours contain double the protein compared to wheat flour. So you're instantly changing the profile of the product to be less carbohydrate and more protein. And we've heard earlier about the diets where the protein is higher, etc. But the sustainability story is the most compelling because they can thrive they have a nitrogen fixing ability, so you don't need nitrogen fertilizers, and they also make the soil really good for crop rotation. So it's really a healthy and sustainable, which is really great. And we've partnered with the University of Reading on a project that's called Raising the Pulse. So this project is all about how can we bring more pulses into the diets of the UK population to improve the health of the mainly underprivileged areas, actually. They're doing some pilot studies in some areas of the UK which are underprivileged, and they're looking at the pulses, not just from how do they work in a biscuit or a snack, but from farm to fork. So how can they grow them? How can they bring the cost down? And we are giving up our time, expertise, and our testing facilities. We've got a big bakery in the UK, and we will be making the products for them. And they're actually using a bean called the fava bean, which is, we call it broad bean in the UK. And I know it's eaten a lot in Turkey. I don't know, I haven't yet seen it in Georgia, but I've only been here a day. But it's really surprising because we've made some products with fava bean just in our pilot kitchen, and you wouldn't believe that they were a bean flour. It tastes really good, even in a sweet biscuit. So we're very excited about that one. And then finally, innovation. So when you're actually trying to make an existing product healthier, it's really, really difficult because you've got to be as good, if not better, than the original product for the consumers to buy it. But when you're doing new innovation, you don't have any benchmark. So our benchmark in health is health. Okay, so in our health and wellness innovation, we have a specific cutoff for the scores. So any health and wellness innovation that we do has to be really high up there. And we use ingredients, we really focus on the nutrients to encourage. So we use a lot of fruit, nuts, and we will be using pulses. And as I say, anyone coming tomorrow will have the opportunity to try one of our new innovations that is being designed specifically around being healthier with the nutrients to encourage. But we also want to focus on the processing. I'm sure there's not a person here that hasn't heard of ultra-processed and the news articles about ultra-processed foods. So we want to try and make our processing and our ingredients, as well as being healthy, but clean. So we don't want unnecessary ingredients in them. And this particular bar that we've produced is cold pressed, so it's very minimally processed. So this is what we do. You'll learn more tomorrow if you come to the workshop. What I've shared today is it's a typical role in the food industry. It's one pillar that Gemma and I do. We have other work, but I think this is really exciting because it really can make a difference. So happy to answer any questions and any young people. Yeah. Yes.
And does not it cause hemolytic anemia in some people?
Just say that again, sorry.
And there are a lot of people, as I know.
Yes. And as I know, it's one of the most commonly mutated genes in Caucasians, and so people who has this kind of mutated gene are prone to hemolytic anemia when they use these flour beans.
Well, I didn't know, so thank you. We haven't launched any products yet, thankfully, but I'm surprised it hasn't been raised in the project because it's being headed by Julie Lovegrove, who you know. But it's a really, perhaps they do know, and it's not new. It's no. Yeah. Perhaps, you know, it's disappear from the headlines. Yes, yeah. But thank you, that's really good to know. And the amount of cooking. Yes, but I know, and actually, you're right. This is, we do maintain the integrity in terms of the cycle and the process. Oh, sorry, I couldn't hear him. Sorry. Okay, so was there another question? Yes?
Thank you very much for your presentation, first of all.
Thank you very much for interesting presentation. My question would be about palm oil.
Yes.
You mentioned that you removed it or reduced it. And as I know, the palm oil is for shelf life. For the product, right? If I'm not mistaken, I don't know.
It's for the texture, the integrity.
Texture.
Obviously, and because it's 50% saturated fat, it does help with the shelf life. Yes.
And I was interested. Do you have any statistics like how much it cut the shelf life and how business is okay with that? Because there will be obviously some costs with business.
No,
and if there is significant cut, of course it's good for us, but I'm not sure if any business will cooperate with that.
It's a really good point. I can't tell you the exact cost for the shelf life, but what I do know is that we had to change some of our products back to palm oil from Hoso because of the Ukraine war and the shortage of palm oil, shortage of Hoso, and we're moving it back now, and there is a significant increase in cost to go back to Hoso. So you're right. It seems to be that the healthier the products, the more expensive. I'm afraid I don't know the shelf life cost, but certainly there is a cost. The oil is more expensive as well, and it only works in certain products as well. So we tried it in our Vitis Digestive, which is a really iconic product, and it was just breaking on the line, on the production line, so we haven't yet found a solution for that one. But with new technologies, new equipment, you know, there's always an opportunity to improve. But yes, it's more expensive. It's like replacing sugar with fibre. Yeah. It's more expensive. That makes our job more difficult. Because we have to persuade.
Very lucky with your company then.
Sorry?
You're very lucky with your company then, if they are okay with that.
Well, they understand the importance of health and well-being, and we continue to drive that message, and we have to be relevant for consumers as well. But you know, we still have to push. Yeah. Because it's, you know, the business. It's a balance, really. Picking the battles, I call it.
Thank you.
So, thank you. Yeah.
Sorry for interrupting. I know that a very good question season was starting, but we have 2 presenters, and then we will have the whole 1 hour for the questions. All the presenters are here, so you will have time and right to ask. Okay. Now, the next presentation is about the role of the nutritionists and dietitians in public health in UK. So, I know that in Georgia and also maybe in Turkish, it's an issue for us, so we don't have like educational programs for it. Now, please welcome Professor Ariel Aslet Bentley, Consultant Registered Dietitian and Nutritionist from the British Dietitian Association. So, first short introduction.
Right. Thanks. Thank you very much for the introduction. I'm delighted to be here in Georgia. I want to just say a big thank you, first of all, to Manana, also to Ika and to Julian for all the help that they provided to ensure that we got here safely. So, yes, I'm going to talk about the role of nutritionists and dietitians in public health in the UK. And I'll just say a little about myself, but I will be bringing in some references to the work that I do when I continue with the presentation. So my background originally was in biochemistry. After that, I did a master's at the forerunner of King's College London, Queen Elizabeth College, and that was in nutrition. And then I did some work, I became a lecturer for a little while, but then went to Oxford University to do research in nutritional biochemistry. I then returned to academia and decided that actually working with test tubes in a lab wasn't what I wanted to do for the rest of my life, and that I wanted to work with people. So I decided that I wanted to become a dietitian so that I could do clinical work. And I did the postgraduate diploma in dietetics at what then was Leeds Polytechnic. So I'm a registered dietitian. I'm also a registered nutritionist in public health. And I've got 1 or 2 other qualifications to do with higher education and teaching. And at the present time, I work as a consultant registered dietitian and nutritionist in public health. And I'm the vice chair of British Dietetic Association Public Health Specialist Group on the committee. That's a small group of dietitians who specialise in this area. And we cover different aspects of it, but we work together very well. And I'm really privileged to be working with such good colleagues. And we also have, at the moment, 3 students on our committee, so that we cover their perspectives as well. And we've got 1 student at the moment who's actually a director for the BDA, because there is a student director role, and he's helping us a great deal. And then another little thing that I've been doing is I'm a co-lead for the Centre for Sustainable Healthcare, Food and Nutrition SUSNet. So that's only a minor part of my work. Some of my work is volunteering,
I also do some paid mentoring work, and I do some work with nursing homes, particularly one that's a specialist mental health unit, where I work with a nutritionist who I mentor. She's relatively inexperienced, but we've worked together there, doing a lot of work to improve the nutrition. We've gone through everything, the menus, we've written a food policy, we've produced a hydration policy, we've saved the nursing home a lot of money, and we've increased the satisfaction of the residents. So that's been very successful. So enough of that. So let's get on with the next slide, which is just an outline of what I'm planning to do. So I've done a little introduction. I'm going to just look at some general definitions, and then I'm going to focus in on the Academy for Nutrition Sciences. And in relation to that, we'll look a little bit at the members of the association, sorry, the Academy for Nutrition Sciences and their public health relevance. Then related to that, it all interlinks. I'll be looking at current issues in the UK in public health, nutrition and dietetics, and what the scope of public health areas of work are. And then some other aspects of UK public health, nutrition and dietetics, and a little focusing on registered nutritionists and a little focusing on registered dietitians. And then I'll conclude, hopefully, with a way forward, because I'm hoping that today's lecture will help to inform the people in Georgia and people perhaps from Turkey, where the situation is rather different to what we've got in the UK. And we do have a lot of resources, and things are quite well set up. So there are lots of ways, I think, in which we could work together, and the people who are developing things in overseas in those countries I've mentioned, including your own, those of you from Georgia here today, we can help you. You may need to modify things, obviously, but there's a very good resource base already available that could be used to support your work going forward. So, I know we've been talking about public health or nutrition all day, but I like to just make sure that people are aware of definitions. So, public health nutrition, really, it covers the nutrition aspects of public health. It's not really rocket science, but just to bear in mind that we're bringing nutrition and public health together. So there are a lot of different aspects of public health, but this is the nutritional focus that we're looking at the present time. And the Nutrition Society do have a textbook on public health nutrition, which I would recommend to anybody who hasn't actually seen it. And their definition is the science and art of promoting and protecting health and well-being, preventing ill health and prolonging life through the organised efforts of society. If you actually put nutritional in front of science, then that would give you another possible definition of public health nutrition. Now, there are more definitions than the ones I've picked there, but these are selected ones which I think are quite useful. But it's really a matter of personal choice which one you want to use, and might depend on which area you're working in. So I'm going to move on now and look briefly at the Academy for Nutrition Sciences, which is abbreviated to ANS. We do use a lot of acronyms in public health, nutrition and dietetics, so apologies if these keep coming up, but at least hopefully you'll have an idea what they mean. So this is a relatively new organisation. It was founded in October 2019, and it brought together 4 existing important member organisations. And the reason that it was formed was because it was felt that the information was not getting across to the public as well as it should do, and there were a lot of concerns about misinformation to the public. So that was really what it brought together. But these organisations have all been going for quite some time, and we're already working collaboratively at times
between one another and sometimes as a collective. But it's formalised that, so it's brought them much closer together than they used to be. So we've got the Association for Nutrition, abbreviated to the AFN, the British Dietetic Association, which is often abbreviated to the BDA, but unfortunately that's the same acronym that is used for British Dental Association, and at the moment I'm actually doing some work with the British Dental Association, so we're having to be quite careful that we don't mix one another up, so to speak. And the British Nutrition Foundation, that again gets abbreviated to BNF, and the Nutrition Society, and there have been various abbreviations for that. At one time it used to be NUTSOC, but that seems to have gone out of fashion now. So the objectives of the ANS then are to focus on improving public health and well-being. And to back that up, they are trying to achieve excellence in various areas such as communication, education and research. And it was, as I say, it was the communication aspect really that brought about the founding of the ANS. They also want to advance the knowledge base and also enhance the application. And they're very much about evidence-based nutrition science, and that's come up a few times today. So this links in with quite a few of the other presentations, and there are lots of links today, I think, in what I've got to say with things that have been presented by the other speakers. And thank you very much to the other speakers as well for all the excellent presentations. Coming on to the Association for Nutrition, and I put the websites up in case anybody doesn't know them. As I say, this is really focused more at people not familiar with these things, so I apologise to people here from the UK if you can bear with me, but hopefully there'll be something new that you learn today. This was launched relatively recently compared to the other organisations, apart from, of course, the ANS. So 2010. And the real reason it was created around that time, it goes back a little bit further, but in 1994, the person who was the head of my department, Professor Eleni Maunda, called together quite a number of nutritionists who were academics from across the UK, because we were looking at how we could cope with placement problems with dietetics. And when we got together, we realised that there was a gap and that there was a big need for more people working in the community, and perhaps not necessarily as dietitians, but as nutritionists. So then the next thing was to try to actually make a new role. And then from that, it was decided that perhaps there needed to be a voluntary register of nutritionists. So that's what's called the UK VRN. So that first was managed by the Nutrition Society, and it's that voluntary register where people who, like myself, registered nutritionists are registered. And there are different types of registered nutritionists, but the ones that do public health have public health after they are nut in brackets. Not everybody bothers to put it in because it's a bit clunky, but that's how it should really be. And then the associate registered nutritionists are A-Nut, and they're relatively newly qualified nutritionists who need to get at least 3 years experience before they can become registered fully to become an R-Nut, and sometimes it takes them a bit longer, and they have to go through another process with the AFN to show that they've managed to reach the right level of competency. So this sets and rigorously applies standards, and it's very much again about evidence-based nutrition and in terms of practice and advice. It's important at the bottom there to be aware that the UK VRN is the only register of qualified nutritionists that the Department of Health and the NHS recognise. But there are other nutritionists out there who are not as well qualified, who have actually started using the title registered nutritionist sometimes. So one has to be a little bit careful. That's not to say that they perhaps know nothing about nutrition, but they haven't done an accredited course, and they haven't reached the same level of competency for sure as is assured by the Association for Nutrition, because all the nutrition courses that are accredited by the Association for Nutrition have to meet a lot of criteria to make sure that they're covering everything in the right depth. And the universities have to go through quite a lot of procedures to reach that standard. But there are a lot more courses now. When I was working at Leeds Metropolitan University, later Leeds Beckett University, we were the second course to get the accreditation. But now I think there are about 60 courses that are accredited. The number of nutrition courses has increased massively. Now, the Association for Nutrition do keep some figures for numbers, but they don't do a proper breakdown. So I asked them, but they couldn't tell me how many registered nutritionists were on the register at the time. But they've got, I think, about 4,500 people on the register in total. So from the AFN perspective, we can look at definitions of public health nutritionists again. And they are, for public health nutritionists, develop, implement and evaluate nutrition policies and programmes. And I'll be saying more about that later. And it's also about expanding the evidence base. Once again, the emphasis being on evidence. And then the application of scientific knowledge, so that the impact of food on diet and health and the well-being of, could be individuals, but mostly it would be groups and communities, are assured. And then health improvement via improving diet and nutrition, and again for the same sorts of groups. So there's a link there for anyone who wants to have a look at that further. Then the AFN does have some points about public health nutritionist career profile. So things that they might be actually doing are addressing under or over nutrition, both at home in the UK and overseas. And we've had, already today, we've had quite a lot said about under and over nutrition. Then it does mention illnesses, but it says assisting, because really when it comes to therapeutic aspects, that's much more the role of the dietitian, but there is some overlap. And this is where sometimes it gets a little bit confusing. And it can very much depend on the particular job that the person has. And there aren't really enough dietitians, so there are some cases where registered nutritionists work with a dietetic department or in a dietetic department, but they usually work under the supervision of the dietitian or dietitians so that the clinical aspects are covered properly. And they may carry out some roles that perhaps normally would be done by a dietitian. But that's, it's not very often that happens, but it does occur sometimes. So some more references there, and there's also something about registration and competency requirements, but I haven't really got time to go into that today in much detail, but I'll just be saying a little bit. So those are the two forms of registration that I've mentioned. And again, it's emphasising evidence-based information and guidance. And there are 5 competencies, which I'll come to in a moment. And as I say, it has to be an accredited degree or a postgraduate qualification for registration. And we have to re-register every year, and when we do so, we have to sign to say that we are abiding by the Code of Ethics, to make sure that we don't do anything that wouldn't be considered appropriate. So these are the the 5 competency areas which are considered to be core, and they include nutrition science, food and feed chain. I don't think that's perhaps the best way to describe it, feed chain, because it's a bit confusing, but it's actually referring to animal food, so that's why it's called feed chain. So we do have animal nutritionists who are registered with the Association for Nutrition. And then there are the behavioural and social aspects, which are very important. I'm going to say a little bit more about later. Then people who are focusing on health and well-being, and then people who are focusing on the professional, well, everybody has to cover the professional aspects. And those different competencies, to some extent, reflect the key career profiles for nutritionists. But every registered nutritionist has to show that they are competent in those 5 core competency areas. And each year we have to do quite a lot of CPD, continuing professional development, to ensure that we're keeping up to date with everything. And that's part of what we're signing up for when we re-register. So public health is there at number 1. And then there are clinical and clinical nutrition and dietetics aspects. And that would be the sort of role that I mentioned, where a registered nutritionist might be working with dietitians. There's a food industry, and we've had a very interesting talk today about the food industry, so another area, and that would include corporate nutritionists as well. And then research, working in universities, teaching, some of that can overlap. Sports and exercise nutrition, it's quite a popular area. And then the animal nutrition, there aren't as many people that cover that area, but it is one that is included. And there's also the international aspects of working overseas, particularly with low-income countries and places that are going through a lot of development or problems and things. Right, so moving on now to the British Dietetic Association, and just to mention, you probably noticed at the top, but there are a couple of icons up there, so if I can manage to spot them. So that's the Public Health Specialist Group logo there. That one is to say that you're a registered nutritionist. So if you've registered, you're allowed to use that. Oh, sorry. Sorry about that. Yeah. So just repeat. That's the one if you're a registered nutritionist. Is it working? Yeah. And the other one is for the Public Health Specialist Group. So the British Dietetic Association has been going for a long time. The first dietitian reported to have the role was in 1924 in Edinburgh. But it took another 12 years before the BDA was actually formed. And it's now not just an association, but it's also a trade union. There are a lot of members now, and it's grown enormously while I've been in the profession. So early in my career, there were probably about 2,000 members, and now it's around 11,000. But it does include different aspects of membership. So we've got students, we've got overseas and international members, and then we've got some other members that are not necessarily nutritionists or dietitians, but they might be people from industry, or they might be nutritionists who want to be associates. And it's got quite a lot of specialist groups, and again, those have grown. They've grown since the 1970s. And one of the first ones to form was the Community Nutrition Specialist Group, which is the one that the Public Health Specialist Group grew from, because that evolved and changed its name. So that was I think it was the second one to form. The first one was a renal group. But public health covers a lot of different areas, so some of the other specialisms are really sort of quite important to public health. It's really a broad subject. So, for example, it covers the lifespan, it covers obesity, sustainable diets. They used to actually be part of the public health specialist group, but then they went on their own. So, if you're in the public health specialist group, you've got to really have a good knowledge of a wide range of areas. And we do quite a lot of collaborative work, so we do events together with some of the other specialist groups. And we also, within the British Dietetic Association, we work alongside academics and practitioners so, to ensure that students get the right kind of training and also that research supports the evidence base. We also collaborate and work with the, what is presently the Healthcare Professions Council. So that is our professional body, and that's who we register with. So it's a little bit different for dietitians than it is for nutritionists. The HCPC, it's evolved for a long time. It was called the Council for Professions Supplementary to Medicine, and then it became the Healthcare Profession Council. But it's, the present one has been going since 2015, and it's not just for dietitians, so it's for other healthcare professionals, particularly allied health professions. And we do quite a lot of collaborative, multidisciplinary work with other groups to enhance and inform other people who work within the health service or outside and beyond it. And another aspect of our work is what we call co-development. So we're very keen to work with the people that we're trying to help and serve, because it's important that we get their views on things if what we do is going to work properly. So that is really, I think, quite a big change to how it used to be a long time ago. A long time ago it was very prescriptive, but it's much more inclusive now than it used to be. The BDA does actually work with a lot of external organisations, and it has partnerships with some of the food industry. It is quite selective because it tries to choose companies which are ethical and support evidence-based practice, etc. But that's an area, again, that's developed recently. And in the public health specialist group, we do get quite a lot of requests from these external organisations to help them with their documentation, their policy making, and their strategies and so on, and sometimes some of their resources and visual aids. And I'll give you an example of that a little bit later. And then it also has, and I think this might be quite important for people in Georgia, it has a lot of resources. And most of these are available free to the public on the website. So you just have to look for the right aspect. We have fact sheets about all sorts of things to do with dietetics. We have policy statements. For example, not too long ago, we produced a sustainable diets policy statement. And within that, it made it clear that all dietitians should be promoting sustainability and practicing it themselves, both in their work and in their own dietary intakes. And the BDA also runs quite a number of different courses for CPD. And the same thing happens with the Nutrition Society. So there are quite a lot of sources, as I say. The key publications are the Journal of Human Nutrition and Dietetics, and the main book, which just gets reviewed every now and again, and another edition comes out, is the Manual of Dietetic Practice. And that first came out about 1986. And I wrote the section on infant nutrition in that one, and also a section on special care baby units. Right, so there's some more definitions there. I think we'll just skip over that because we've kind of covered those. But the BDA takes a little bit different, and once again, however, there's a big focus on evidence-based practice, EBP. So what do public health dietitians actually do? Well, public health dietitians, according to the BDA website, work with groups of people, and they improve health by advising them on what they eat and drink, and through nutrition education and to the public, and they work with communities so that access to healthier food is made easier. And again, you can look into that further. Moving on now to the British Nutrition Foundation. This is a charity that tries to work with the public in particular. It goes back to 1997. It originally was quite closely linked to the food industry, and sometimes it was criticised a bit because people felt perhaps it was being a bit too much influenced by the food industry. But it seems to have moved away from that situation now, and it does a lot of education. The patron is Princess Anne. She does come to meetings, and she takes the work that she does with the BNF very seriously. And it's already been mentioned today, but they run the Food A Fact of Life programme, which is very useful, and it runs really quite frequently, and there are lots of older resources that you can look at and get information on how to do interventions in schools. It also has a public health and sustainability focus, so they've been doing quite a lot of work around those sort of areas, and it works across nutrition and different people involved with food. Again, it uses evidence-based approaches to practice, and it tries to help people change to a healthier diet and a lifelong healthier diet. Once again, it's got a lot of useful resources, and there's a bulletin that comes out regularly, and it runs other training programs as well. The Nutrition Society, which we've come across before, that goes back to 1941. Some of it's been mentioned already. It's definitely got a strong research focus, and it's about advancing nutrition from all sorts of different points of view. And the 6 different journals look at different perspectives, but the key one really is the one on public health nutrition from this point of view. There's also the Nutrition Society Gazette, which is a newsletter that brings you up to date and tells you what conferences are running and things like that. And a lot of the publications now are going towards being open access, so that's useful, because even people who aren't members can get access to the papers. It does have some specialist interest groups, but they're a little bit different to those with the BDA. For example, there's one that is run by one of the members of the Public Health Specialist Group, and that's on the workplace. And that's the person who's the chair of that is someone called Rachel Gibson, who works at King's College. She's a lecturer there. And she's been doing a lot of work around shift work and how that can affect health and how it affects nutrition. And then also it provides the conferences, and it's got a webinar platform which is called the Academy, and that's there for CPD and for people who are studying and wanting more information on specific topics. So having just looked at that now, we now need to focus on what is actually covered. So it's about prevention, but also intervention. So we're trying to prevent diseases like the non-communicable diseases, the NCDs that I've been talking about again today. But we also have to intervene in order to actually make a change and produce appropriate outcomes. Public health nutritionists and dietitians mainly work with groups and often at the population level, and this is where things can be a bit difficult because some of the resources, people want to use them for one-to-one work, but they're not really aimed at that. They're perhaps being produced really for working with groups. And the Eat Well plate is an example of that because it's very often used for individuals, but it does need a lot of sort of adaptation if you're going to be able to use it with certain different people who've got different needs. However, there are some other versions of that, and I'll mention that a little bit later, some of which have been produced by members of the British Dietetic Association. So we go really right from one-to-one up to the global level. And some people will perhaps cover quite a number of those different aspects. Other people will just focus on one particular aspect. And as I've said before, it's one thing that really interests me in nutrition and always has, that it's such a broad subject. It's got so many different facets to it. But all the time it's expanding, and it's really getting quite difficult keeping pace with all the research that's going on. There's the difference of the one-to-one and the group work, which I mentioned before, that kind of separates the nutritionists and the dietitians. But it can be a lot of work at the public interface, which we tend to call hands-on work, grassroots work, working directly with people who've got a lot of problems. So we do a lot of focus on vulnerable groups and people who are perhaps suffering from health inequalities due to dietary problems or food insecurity. And then there are other aspects that are more sort of desk focused. So epidemiologists might not actually go out and work directly with the public, and people are working on policy development. It will depend on how they're doing that. Some people will be doing that perhaps mainly away from the public interface, whereas other people might be directly at the public interface gathering data and information and so on, and then translating that into a strategy and then a policy. And then of course we've got the continuum professional development aspect, which is needed by both the AFN and the British Dietetic Association to keep up to date with our competencies registration. Right, just a little bit about my career. So I've been around quite a long time. I'm not going to say how long, but quite a long time. And I've done a lot of different types of work which have linked into public health, nutrition and dietetics. One of those, which might not sound initially as if it's got much to do with nutrition, was working for Rentokil. I worked with them as a field biologist in pest control. But the good thing about that was I learned a great deal about the food industry, because I used to have to go to all sorts of different types of food manufacturing plants. I used to go to farms. You know, it was kind of like the farm almost to fork situation. I covered all sorts of things, and I learned a lot about the food industry by going and doing that, because if I went to do an inspection, I had to go everywhere to check. So that was very informative. I worked in Aberdeen as a lecturer in nutrition and dietetics. I also was a metabolic research dietitian at Leeds General Infirmary doing calcium balance studies and all sorts of other things for some time. But that didn't have a particularly strong public health focus, but there was a little bit, I suppose, because I did some more general clinical work as well. I also worked as a nutritionist for Carngate, and I mostly worked with other healthcare professionals who were working at the public interface when I did that job. But I did some work directly with the public, and a lot of work with people who were dealing with the public, so people like health visitors and nursery nurses, even consultants, mainly paediatricians, all sorts of different people. And that was a very interesting job, and I was also involved with advising on product development. And we've just been looking at that with the previous speaker, but obviously from a different perspective when providing things for infants. Then I had a freelance business, which I did for a while, and then later I had a dual role as a community dietitian and working in Pontefract, and a lecturer in nutrition and dietetics at Leeds Polytechnic. It was at that stage really that my academic work started to focus a lot more on public health than it had done previously. The rise in NCDs at that time was becoming an issue. It was the 1980s. We did have the NACNI report. That was very important. Actually, it changed a lot of what we did. Then later on, I became a senior community dietitian, and I had special responsibility for people with learning difficulties. That was a special part of my job, but I did a lot of more general things and a lot of nutrition facilitation work in that as well. Did a lot of work with schools, childhood obesity, paediatric allergies, all sorts of things. Then after that, I went back up north. I'm from the north, from Yorkshire. I was born in Leeds, and I went back to what had been Leeds Polytechnic, and became a senior lecturer in nutrition and dietetics there, and the course leader for the postgraduate diploma in dietetics. So I worked there for a long time, and during that time I embedded a lot of public health into the modules that I led, into the courses that I was the course leader for, and so on. And we did a lot of work in the community, and the students got involved. They did all sorts of projects that were related to things like schools, supermarkets, all sorts of things. And then it came really to what I'm doing now. So then I started freelance consultancy work and volunteering, and some of the things, you know, that I've already touched on with the... First of all, I was with the British Dietetic Association Yorkshire branch, and then the Public Health Specialist Group. So the key things that really I cover now, health inequalities I've mentioned, food insecurity, and particularly the cost of living crisis, and related to that, sustainability. As I say, I work with other people who are specialised in things.
Sorry, Manana says, can you wrap it up?
Yeah, okay. Okay, right. So, just to finish off with the scope of public health nutrition, I've got a list of things here, and then I'll show you an infographic that we've been working on. So, a lot of the work that we do is working directly at the public interface in interventions. So we're doing assessing, we're monitoring things, we're doing surveillance, and we're looking at nutritional status. And the first thing really that needs to be done in those sort of projects is to do a needs assessment. That's really important, because unless you find out what the community needs, it's likely you're not actually going to get the project right. I work across different aspects of the lifespan, which I've mentioned already. Work with local authorities, schools, social groups. There are also, I mentioned the vulnerable groups and the food industry aspects, and then running NHS group education sessions with people with NCDs. Yeah. Some of these we've touched on already, so I'll skip over them a little bit. Food insecurity, health inequalities. The campaigns, things like cook and eat sessions, and then community participation and engagement, because it's very important to get the people that you're working with engaged and focus on behaviour change and how to motivate them. And we use whole systems approaches wherever possible, so that in a school, for example, we wouldn't just work with the children, we'd try to work with the whole school and bring everything together. So address what the cooks are making, the school meals, we'll speak to school meals organisers, we'll work with the teachers, we'll work with the parents, the pupils, etc. So hopefully we have as big an impact as possible. Then looking at food-related illnesses, that's nutritional epidemiology, data handling, lots of collaborative work, and improving nutrition and sustainability, and then development work and strategies, etc. So this is a little bit busy, but I'm just showing you this because it's something that we've recently been working on, because we were asked by the OHID, the Office for Health Improvement and Development, to put together an infograph, on the different aspects of work that we do. So they wanted just a summary on the health promotion aspects that we do, how we actually address the population's health care and the wider determinants of health that are important in nutrition, and then how we go about health improvement. So that's actually still a work in progress, but it's gone ahead for some graphics to be added to it to make it sort of nice and pictorial. And then there's just a little note at the bottom about what dietitians like to do. Every allied health profession is producing one of these. So I think there are about 15 of them altogether, but they're all meant to have a similar format, and it's to help to inform the public. Right, just mention the, play it very quickly. That's actually a Spanish version, which I used on purpose because it does get converted, it gets used by all sorts of different groups. So there are other versions for different ethnic minorities. There's a vegan version, and so on and so forth. So although the original one isn't necessarily going to be exactly appropriate, some of them get changed, and so they're made more suitable. But there are always problems with trying to use these population-based resources with individuals. So that needs more attention for you, which I think it's going to be revised again. Another one that I just wanted to mention because of its sustainability aspects is the Lancet recommendations. But I have to say, the BD on the whole, think that one's really a bit too difficult for people to put into practice. It's rather too demanding. I think it's too many changes too soon. So we're not really following that one exactly at the present time. So to conclude, there are a lot of areas where public health nutritionists and dietitians work overlaps, but also a lot of similarities. We're working in a difficult time. We've got all the problems of the cost of living crisis, we've got climate change, we've got food supply problems, we've got high rates of non-communicable diseases, food insecurity, etc. So it's a very challenging time, and how we're going to deal with all of these things is yet to be decided. But there's certainly plenty of work for nutritionists and dietitians, and really we need more of them. And the scope is expanding all the time, but it's good to see that the HCPC has now embedded public health aspects into their standards, because they have standards of competency. Sorry, I think there's a typo there, for all dietitians. So it's not just the dietitians that work in the community, but the ones that do the clinical work as well, have to be able to deal with the public health aspects, even if they're working on a one-to-one basis. So I'm going to finish at that point, and thank you very much for your attention. If there are any questions, I'll answer them later. Thank you.
Thank you very much, Professor. So now, before the last one, I have a very good news to you who are still here with us. There is a gift basket from our company, Sante, on the right side of the stage. Please go and take it. It's for free. I think there is more outside of the conference room, so please don't hesitate. And at the end of this day, I want to invite Dr. Madana Stanley, the president of Georgian Nutritional Society, to sum up of this day. And then they will go the questions.
Before I outline my presentation, I would like to thank all the speakers for fantastic presentations, and I'm very happy that we had such a enlightening and informative conference so far. I'd like to say a few words about I won't be very long. I know you probably are very tired, end of the day, but I'll talk a little bit briefly about developing nutrition and nutritional science in Georgia. That I regard as an important consideration for public health. The Georgian Society aims to promote nutritional and nutritional science through adequate education and practice, as well as regulation in the field of nutrition. Our society strives to educate the Georgian population on the medical importance of nutrition, on the role of nutrition on incidence of some non-communicable diseases that are linked to the modern way of modern eating habits and lifestyle. We also aim to communicate with relevant policymakers on the role of healthy nutrition in the development of public health policy and its economic benefits, on importance of training business operators in food safety risk assessment, and educating them on the health implications of food they produce or import. As Georgia became more westernized, alongside with other recent trends, eating habits and lifestyle have changed significantly. Such major changes create additional health challenges. So there is a good deal we can learn in terms of current developments in nutritional science and new approaches. These are developments that identify the importance of nutrition in preventing and treating various non-communicable diseases. These challenges emphasize the need for nutrition education and the importance of raising the profile of nutrition and nutritional science in general. This includes learning from the experience of the countries where nutrition and nutritional science is well developed. Given their extensive research on the harmful effects of modern diets, that are associated with the diseases like diabetes and cardiovascular disease and cancer. Contemporary research in Georgia is at a very early stages of development. Hence, to study and implement the best practices in the world on a wide range of topics concerning nutrition and health is particularly important. Public health professionals know all very well that it's much easier to prevent disease than to treat it. So the healthy eating being a principal means for this. Hence, learning and exploring health benefits of developing nutrition and nutritional science attracts many Georgian health professionals and academics. In particular, I would like to mention the young generation who are very keen to contribute to develop nutrition and nutritional science in Georgia. Traditionally in Georgia, there has always been interest in nutrition, and there is historical evidence of knowledge of the health benefits of certain types of food. Well before modern-day scientists started to explore it through their research. Institutions such as Institute of Sanitary Hygiene and Medical Ecology and Department of Medical Nutrition at the Medical University, Tbilisi Medical University, began to investigate it in the last century. However, the very difficult times existed in the last 30 years in Georgia, nutritional science has been somewhat hampered. Georgia's rich gastronomic traditions, variety of food and eating habits and lifestyle, I think deserve exploring. The health beneficial effects of a Mediterranean diet have been well researched, with many Western countries recommending it to their population. Applying similar reasoning, it would be very interesting to look at our local regional diets in the Caucasus, especially given traditional longevity in the region. This underlines the importance of involvement of our international partners in exploring potential areas for collaboration. With the current government policy putting emphasis on education and developing science, we hope to carry on projects investigating possible beneficial effects of certain aspects of Georgian cuisine on preventing disease and maintaining good health. This would involve exploring the beneficial effect of local food and variety of mineral waters found in Caucasus mountains, benefits some of the traditional Georgian and traditional food on gut microbiota and foodborne disease. We are delighted to announce that Nutrition Society of Great Britain and Ireland is helping us to set up several education programs, and among those are continuing professional development via webinars that are offered by the Nutrition Society Academy, access to academic books, and the university-level courses in nutrition and dietetics. They also offer courses in nutrition for medical students as well as working doctors. For the future, we would like to organize a regional conference in 2024 where we hope to discuss the health implications of the rapid replacement of a traditional diet with a Western-style diet, high in sugar, salt, and refined food in our region. Implication of those changes on increasing incidence of type 2 diabetes, cancer, and cardiovascular disease, well known to everybody, major causes of morbidity, high morbidity, and mortality. Importantly, we propose to host the initial meeting of the Forum on Nutrition and Health on the fringes of 2024 meeting to consider establishment of the regional forum. This will aim to provide a platform for leaders in nutritional science and health professionals, together with policymakers, farming industries, and food companies, to initiate projects together for the good of all. It will further develop a common understanding of the evident but complex relationship between the food we eat and our health. The different parties having opportunities to exchange knowledge and ideas, to find common ground and collaborate in the task of reducing the current incidence of several non-communicable diseases with high mortality and morbidity levels worldwide, situation which is causing serious financial burdens in the healthcare systems in many countries. That's what I wanted to talk about, and thank you again for coming. Thank you for all the presenters for giving us this fantastic, all the speakers giving us all these fantastic presentations. And also we are looking forward to tomorrow, where will be webinars, workshops held at Natazi Institute of Sanitary Hygiene and Medical Ecology, which is addresses Natazi 78. So I am hoping to have you all tomorrow to attend these workshops. Thank you very much again.
Thank you for your patience and thank you for staying with us this late. I know we overcame all the possible timing. So now, if you have any questions, any comments that you wanted to share with us and we didn't give you a chance until now, please feel free, let us know, show your hand and we will give you a microphone and we will listen to you. Thank you.
Don't be shy. We know that you were waiting for this moment.
Whole day, yes. Yes, please, yeah.
I am the chairman of Sabri Ülker Foundation, and I have found this meeting as a very specially organized, and thank Julian for his efforts, and thank to everybody who came and speak about nutrition. Actually, a question in my mind is related with the a problem of, for example, alcohol. We talk about tobacco, sugar, salt, and everything, but alcohol is not considered in this equation. Also, opium and similar material, for example. I think this should be, in the future, much more concentrated and studied. Thank you again for coming, and thank you again for collaboration and cooperation. Goodbye.
Thank you very much for your kind words. We're also very grateful for you to come and visit us. If anyone else wants to share their thoughts, ask any questions, or give us any feedback or ideas for future upcoming conferences, please feel free.
Hi, first of all, thank you for all the presentations. It was really interesting. I have a question to Ms. Avril, who talked about the role of nutritionists and dietitians in public health in UK. You talked about